and I'd want to introduce you Dr. Diamanti. She's an oral pathologist in our university, and she was mentoring us the whole time. So please, doctor.
So thank you, Daniel. Good morning, everyone. And thank you for joining us at this early hour on Saturday morning. As Daniel said, today our team, comprised of 5 talented students from dentistry and medicine, will be presenting intriguing clinical cases. Our aim is to highlight the significance of oral lesions as indicators of systematic diseases and emphasize the importance of intra-professional collaboration. As we all know, the oral cavity serves as a potential site for manifestation of numerous systemic diseases. And in some instances, oral lesion may present as the initial manifestation of an underlying systemic condition. Therefore, it is crucial for all health professionals to be capable of recognizing these manifestations, facilitating early diagnosis and prompt treatment initiation, and all that for the benefit of the patient. While the range of systematic diseases manifesting in the oral cavity is extensive, of course, it is impractical to cover all of them within our limited time frame, of course. And so we will be focusing on the most prevalent and clinically significant ones. Anna, Christina, Michaela, ladies first, and Daniel and Spiros will present these cases shortly. So thank you once again for your presence and attention, and we hope you will find our presentation informative and engaging. So Daniel, the floor is yours.
Thank you so much, doctor, for the lovely introduction. Okay. So, as we said before, my name is Daniel Carney. I'm a 4th-year dental student, and today I wanted to talk to you about, I'm going to do the introduction to our roundtable, and my title is Connecting the Oral Cavity to Systemic Diseases and General Health. So, first of all, I know that you're all med students, so I had to start off with the basic of the basic of the basic. This is a healthy mouth. I know that you guys are not very familiar with it because you skip this throughout your anatomy lessons, but this is the healthy mouth, as you can see here. And in order to identify the lesions, we need to first of all understand what is the normal variations and what are the pathologic variations that we can see. And when we look in a patient's mouth, we're looking for the lips, we're looking for the tongue, for the mucosa, gingiva, uvula, the tonsils, and the oropharynx. And now, this is not a healthy mouth. It's quite noticeable, it's very easy to distinguish. This is a patient with diabetes, actually, and it's been shown that patients with diabetes have very severe oral health. But in general, many entities can be seen and diagnosed early. The oral symptoms can be sometimes the first, the only, or the most distressing features of a systemic disease. And we as clinicians, all of us, must not separate the mouth from the whole body. So again, just for the basic of the basic, we in dentistry, when we treat diseases, usually we have the basic diseases that we treat are dental caries, which are the most common chronic disease in the world. which affects around between 50 to 90% of the population. And it's caused by basically bacteria and breakdown of the teeth. We have periodontitis or gingivitis, which is also caused by bacteria. Basically, all of the diseases in the oral cavity that we treat as dentists and not oral pathologists, but also there, are caused by bacteria. And actually for this stuff, so for the root caries, for the gingiva, for the periodontitis, sorry, routine plaque control, so just brushing twice a day for 2 minutes of the dentition and the tongue can prevent these diseases. Now, there is a synergetic effect between the oral cavity and the body. So there is a pathway of infection from both sides. You can either have a systemic disease that will infect your oral cavity, or you'll have a condition in your oral cavity, such as very aggressive necrotizing gingivitis, for example, that can affect your body. So there are 3 pathways of infection from the oral cavity systematically. One of them is the metastatic spread of the infection. So the oral infection can go through the bloodstream during episodes of bacteremia. Another one is metastatic toxic injury. So the toxins that are produced by the microorganisms enter the circulatory system and causes harm to other tissues. And finally, metastatic inflammatory response, so the body responding to the toxins or to the pathogens that we have in the oral cavity. And again, when we prevent these conditions by just doing simple plaque control, and by plaque I mean just bacteria biofilm that sits on the teeth and on the soft tissues. These are all preventable. And now for the stuff you came for. So in the oral cavity we can see a lot of disorders. Okay, it's actually quite endless. We can see disorders, syndromes, hematologic disorders, autoimmune disorders, gastrointestinal, like Crohn's disease can be one of the absolutely first indications. Nutritional deficiencies, we can see B12 deficiency, for example. Viral, bacterial, and fungal infections. Tumors, we have many tumors in the oral cavity, either metastatic or benign. Dermatoid infections, drug-induced manifestations, and other dental disorders. So here I just wanted to show a small representation of the infectious diseases or the immunosuppression ones that we can see. For example, the picture on the left, we can see hairy leukoplakia, which can be the first sign for actually HIV and AIDS. So this is very important for us to take notice. On the right, we can see candidiasis, which could also be a sign for immunosuppression. We can see ulcers, we can see herpes, HSV infections, etc. A few examples, we can see herp angina, which is basically just ulcerations that are exclusively on the soft palate, and also histoplasmosis. We can see on the left, which is the most common systemic fungal infection. Very important, extremely important, is oral cancer, especially for the risk group, and the risk group is men above 50 years old, smokers and drinkers. We're in a Mediterranean country. I think most of the men here are like that, so it's very important for us to know this. and it's one of the top 10 most common cancers in the world. So in the oral cavity, we can have a plura of metastatic disorders, but the most common one is squamous cell carcinoma. And the picture on the left is actually in the buccal mucosa. So it's the inside part of the cheek on the left. You can see it. You can see it there. So on the soft tissues of the cheek, and on the right we can see cancer of the lip, which is also very important for us to know, since we have a lot of UV radiation in our countries. So it's very important for us to identify these and be able to take preventive measures and be sure that, okay, this is something, we need to take action, not just ignoring these. This is something that I wanted to just to include because it's quite easy to identify. This sign right there is called strawberry gingivitis of Wegener granulomatosis. And it's basically just you have on the gingiva a swelling and some petechia. It looks like strawberry, so it's very easy to identify, which is the systemic disease. Now, after we gone through all of those, it's very important for me to give you some tools in order to understand what we are doing when just every patient that comes to our clinic here in the 4th floor, we do this intraoral and extraoral examination, and we check basically everywhere. You can see on the photos here, we basically check the entire oral cavity. We palpate it. We look for any abnormalities. Which, to be completely honest with you, it's very hard to identify what is normal and what is abnormal because the anatomic variations are huge. But after some experience, you're okay. We check the tongue, which is extremely important. We take a gauze and we just check left and right. We check the lateral borders of the tongue, which is the most common area for oral cancer to develop. And for the extraoral examination, we check for facial symmetry, which would include, which would indicate infections, trauma, developmental issues, the skin condition, lymph nodes. We do palpation of all of the head and neck lymph nodes, which is extremely important. We check for the TMJ, for the temporomandibular joint. And we check for the salivary glands, if it's swollen, if there is some pain, in order to identify if we have problems there. Now I wanted to show you a case by Dr. Diamanti. So we have a 30-year-old man that came to the ER after not being able to eat for 3 days. He had fever, and they found some bilateral submandibular lymphadenopathy, so swelling in his lymph nodes in the submandibular area, which is right there. When he came to the ER, the doctors there initially thought that it was acute tonsillitis, and they they prescribed augmentin and antipyretic drugs and sent him home. And also he had severe pain in the oral cavity. So I don't know if any of you had tonsillitis, but it's quite terrible. So after 2 days, he came back to the ER, and there was a complication. He started having exacerbated signs in his oral cavity, more redness, more The clinical photos here of some ulcerations. So they thought that it was an allergic reaction to the antibiotics. But then they referred him to Dr. Diamanti's practice. And this is the clinical photo that they received, that the clinical representation that they had received. And we can see here swelling in the gingiva. We can see ulcerations here, blisters all over. So so the initial thought of Dr. Diamanti was some sort of herpes, some viral infection actually, not bacterial. So the differential diagnosis for this case would be ulcerative necrotizing gingivitis. It will be herp angina. This is the ulcerative necrotizing gingivitis, as we mentioned before. This is the herp angina. Herpetiform aphthous ulceration, I'm sure that at least 50% of you know what aphthous ulceration is. Now we have 3 types of it, and the herpetiform is this one. And for the herp angina, it's exclusive on the soft palate, so this is a sign that you can identify quite easily, and if you have, and in the oropharynx, so if you have some blisters in the soft palate and in the oropharynx, you should suspect herp angina. And lastly, the herpetic gingivostomatitis, which is actually was the diagnosis of the case that we had, this one. So to conclude, I would just want to give you some general rationale about, about the manifestation management of oral manifestations. So first of all, you need to look for anatomical variations from real disorders. You need to know how to differentiate them. And if the lesion persists, like let's say that we have a lesion that persists for 2 weeks, it is not enough to just it's not enough of an indication for us to do biopsy. We need proper knowledge to do that. And sometimes, as I mentioned before, lesions in the oral cavity are extremely difficult to differentiate due to the similarities of the anatomical, due to the different varieties of anatomical variations. So the best course of action is referral, and actually referral to an oral pathologist would be a wise choice to do so. But understanding the pathway of infection is synergetic, okay? Oral cavity affects general health, and general health affects the oral cavity. It is important for each one of us to educate patients in high risk to perform self-examination, just like breast cancer. If you have people in high risk, you should educate them to do self-examinations for oral cancer every 3-6 months, whatever suits them. But it's extremely important because this can save life, okay? So you have to think about that. And being able to identify healthy and not healthy dentition and oral cavity is relatively straightforward. I don't know if you noticed, but in my first slide, I showed you a healthy mouth and a non-healthy mouth. I think most of us have a healthy mouth, and it's quite easily to understand. So when you see a patient with caries all over, with plaque, not the nicest representation, you should raise some questions. What is happening to him? Because he will probably either developed or already developing something. And he should go see a dentist. Additionally to all the tests that you guys are doing for the chief complaint. And that's it. Thank you so much for your attention.
So, very nice presentation, Daniel. Thank you. And the case that you presented is very characteristic, especially for primary hepatic gingivostomatitis in adult. The history of the disease is the clinical common case scenario in most of the cases. So thank you again for your presentation. It was very informative and also showed our message that the oral cavity can be the sign of systemic diseases, and we should be able to recognize that signs, both dentists and physicians. Thank you, Daniel, once again.
Thank you, Dr. Diamanti. I would like to invite Spiros Vasilakis. He's a fifth-year medical student, and Doctor, would you like to say a few words?
Guys, I was excited to invite Spiros in our team since he is a friend of my son. They started studying together medicine. So I know Spiros quite well, and I was sure that he will present the cases properly. So, Spiros.
So how we're gonna, like Daniel, he will project the slides, how we're gonna work it out. I don't know how we're gonna do it. Will I project dentist side? I don't know.
Okay.
Can you switch to the presentation, please?
Yes.
Can I switch? No, it doesn't let me switch slides.
I will switch for you.
Perfect. So, good morning to all of you. Name, as mentioned before, is Spiros Vasilakis. I'm a fifth-year medical student, and my presentation about the oral manifestation as a first sign of autoimmune diseases. So, my first slide and how we'll begin this presentation is a medical case. This medical case includes a 48-year-old female patient that presents practice with acute pain and problems with mastication and feeding. The clinical examination of the oral cavity revealed bilateral located white papules that enlarge and form reticulate white-gray lines over the mucous surface, white plaques on the dorsal surface of the tongue and on the inside of the buccal mucosa, erosion gingivitis, which is erythematous in appearance on the maxilla. Also, according to the patient, the erosive lesions in the oral cavity cause pain when in contact with food and liquids, and the same clinical picture with erosion has been recognized in the genital area. So, in the next slide, according to the pictures of this particular case that you also see in this slide, together with the accompanying symptoms from the patient, lichen planus sounds as the most possible diagnosis. So, in my next slide, we will mention some general information about the lichen planus. Lichen planus is an acute or chronic inflammation of mucous membranes or skin The autoimmune antigen responsible for the disease is unknown, though. Epidemiologically, is being found usually to people that belong in the age range from 30 to 60-year-old, with females being more prone. Pathophysiologically, briefly, the mechanism involves the activation of lymphocytes that lead to keratinocyte apoptosis. Morphologically, also, more to skin though, it's important to mention, but we will also mention the mucus afterwards, involves the presence of pruritic, well-demarcated violaceous polygonal flat top papules. Common sites involve the wrists, ankles, mucous membranes. In 60% of the cases, though, involves the mouth and vulva and the glands, the nails and the scalp also, and is symmetrical and bilateral distribution. So the next slide. So lichen planus, it's a clinical or histopathological diagnosis. The reticular lesions in the oral lichen planus often happen to be asymptomatic, and they include the presence of multiple papules and Wickham's striae. Thus, the lichen planus is usually confirmed clinically and histologically. When the classic bilateral reticular pattern is not present, which is quite usual, histological examination is required. Furthermore, direct immunofluorescence is being used when gingival and erosive ulcerative lesions are present to exclude other diseases like pemphigus vulgaris, mucous membrane pemphigoid, and persistent erythema multiforme. It is usually negative, though, or we just see it with like cyclofibrinogen deposits and the basement membrane zone with cytoid bodies, also named Russell bodies. Important to note that the chronic course of this condition, the pleomorphism of the clinical features, the importance of long-term treatment and checkup, and the risk of malignancy suggest biopsy as a clinical method to confirm lichen planus. In our next slide, we see some histology slides. It's important to know that histopathologically, this clinical method is subjective and non-specific, but we use it a lot to exclude dysplasia and squamous cell carcinoma because we have increased risk in erosions and ulcers. Some features histologically is Daniel, it's a previous slide. Yes, perfect. We have thickened squamous stratified epithelium, irregular acanthosis, hypergranulosis, hyperkeratosis, and the band-like infiltrate of inflammatory cells beneath the squamous cell epithelium. Now, the Wickham's striae. So the next slide. We see like three pictures that are really distinctive of the Wickham's striae, which are the reticulate white-gray lines, which have a lacy whitish network appearance, milky white in color, with papules and plaques over the surface with erythematous background, which happen to be often asymptomatic. So they might be pathognomic for this condition, for lichen planus, but they might not be present. In my next slide, we have a table that mentions all the types of lichen planus. Important to note is that the reticular one, the erythematous atrophic, and the ulcerative are the three most common ones that we are most possibly find to summon. So, according to lichen planus, spontaneous resolution is rare, and it may last for weeks, months, or years. It is rarely associated with hepatitis C, which is quite important because hepatitis C interferes directly on cellular replication and produces immunological changes, having a role in the occurrence of mucocutaneous lesions of lichen planus. We also have the presence of Kebner phenomenon, which is the appearance of new skin lesions on previously unaffected skin, secondary to trauma. And moreover, studies suggest that the oral involvement occurs in approximately 30 to 70% of the patients with lichen planus as the first sign of the disease. But what's the percentage of patients with skin lesions who will subsequently develop oral lichen planus? It's important to note that not all patients with skin lichen planus will develop oral involvement. However, the risk varies depending on factors such as the severity and extent of skin lesions, and some studies suggest that anywhere from 15 to 70% of the patients with cutaneous lichen planus may also have oral lesions. This wide range underscores the variability in individual cases and the need for clinical assessment. So for investigation, we have to consider skin biopsy and hepatitis C serology if the patient has the risk factors. And now the treatment. First-line treatment It's corticosteroids like clobetasol propionate and triamcinolone acetonide. Usually, patients, though, with asymptomatic lesions do not require active treatment. Elimination of factors and irritants that support the formation of lichen planus, like smoking, alcohol, poor oral hygiene, plaque formation, is really important because permanent cure is not available. As second-line treatment, we have immunosuppressants and immunomodulatory medication, like calcineurin inhibitors or retinoids, which are being used when we have resistance to corticosteroids. And we also use cyclosporin manthrins and tacrolimus, with the second one being more potent and with better absorption. Third treatment involves the use of systemic corticosteroids if severe, painful, and widespread lichen planus is being observed, and topical corticosteroids did not help. Immunosuppressants like azathioprine and mycophenolate, together with phototherapy, are useful if recurrences are possible. Now, we will proceed with the second medical case. Here, in this particular case, we have a 50-year-old male that came to the medical practice with a 2-month history of multiple painful ulcers in the oral cavity, making it difficult for him to eat and swallow food. He noticed a bulge in the left buccal mucosa that later involved the entire entity of the oral cavity. We have no other skin signs. The clinical examination revealed a larger shallow ulcer on the left buccal mucosa, round in shape, irregular erythematous halo. The base on the ulcer was covered with yellow-white pseudomembrane. Other ulcers with smaller diameter have been identified in the oral cavity. Biopsy revealed main acantholytic cells, stratified squamous epithelium, tombstone appearance, and mixed inflammatory cells, plasma cells, and lymphocytes. And all these findings support the diagnosis of pemphigus vulgaris. So, pemphigus vulgaris is an autoimmune blistering disease. We have immunoglobulin G against epidermal desmoglin 1 and 3 that lead to loss of intercellular adhesion in the epidermis. Anti-desmoglin 3 is positive in oral pemphigus vulgaris, whereas both anti-desmoglin 1 and anti-desmoglin 3 are positive in pemphigus vulgaris with skin involvement. We have the presence of flaccid non-pleuritic intraepidermal bullae or vesicles that happen on an erythematous or normal skin base. They rupture soon after their formation. We have painful erosion with ill-defined borders of the oral mucosa that happen before the cutaneous erosions, and some have a wide fibromembranous exudate covering the base of the ulcer. It is being found in the mouth in 90% of the cases, and it is estimated that approximately 70 to 90% of the patients with pemphigus vulgaris present initially with oral lesions and may present with erosions and secondary to bacterial infection. It is a condition with slow healing. We have a positive Nikolsky sign, which, what does it mean? Nikolsky sign is the epidermal detachment with shear stress, and Asboy-Hansen sign is also positive, which is when we apply pressure and it causes the bullet to extend laterally. So the next slide, again for pemphigus vulgaris, epidemiologically we see it in patients from 40 to 60-year-old. It has an equal female to male ratio. Paraneoplastic pemphigus may be associated also with thymoma, myasthenia gravis, malignancy, and the use of dipenicillamine. Lesions heal with hyperpigmentation and do not scar. It may be fatal unless treatment with immunosuppressive agents. Investigation involves the use of immunofluorescence for immunoglobulin G and C3 deposition intraepidermally, circulating serum antidesmoglin immunoglobulin G antibodies also. Treatment is prednisone until no new blisters are found. And in the next slide, we will mention another condition called bullous pemphigoid, which is a chronic autoimmune bullous eruption. We have immunoglobulin G produced against dermal epidermal basement membrane proteins, also called hemidesmosomes, that results to subepidermal bullae. Presentation includes severe painful desquamative gingivitis with vesicles and erosions. They are small in size, bullae and vesicles, and more fragile. They involve a larger area of the gingiva together with a thin white membrane. They heal without scarring usually. They are rarely fatal, and we see it more often in patients from 60 to 80-year-old with an equal male to female ratio. And they have a negative Nikolsky sign in comparison with pemphigus vulgaris. Immunofluorescence shows a linear deposition of immunoglobulin G and C3 in the basement membrane. Anti-basement membrane antibody called pemphigoid antibody detecting serum. And treatment also here is prednisone until clear, topical potent steroids, immunosuppressants, and intravenous immunoglobulin and plasmapheresis for refractory cases. So, and the last one is systemic lupus erythematosus, which is a chronic inflammatory multisystem disease with a known etiology. We have the production of cytotoxic autoantibodies and immunocomplex formation. It has multifactorial etiology. Age of onset is from 13 to 40-year-old, with females being more prone, and especially African Americans and Asians. Important to note is that oral lesions are present in up to 40% of the systemic lupus erythematosus, but are rarely the first presenting sign of the disease. The classic presentation includes orally henoid lesions with atrophy, erosion, hyperkeratotic reticulation striation, white plaque with erythema in the center and keratotic striae, and telangiectasias may also be present. It is different among the different types of lupus, though discoid and systemic lupus have the same or clinical manifestation. Most common location is the heart palate. And we have also other symptoms like oral candidiasis, dysphagia, and xerostomia, and treatment is immunosuppression and corticosteroids. Thank you a lot.
Thank you, Spiros, for your detailed presentation, emphasizing the importance and prevalence of oral signs in mucocutaneous diseases. It is very crucial for all of us to note that a significant percent of cases exhibit oral signs as their initial manifestation. Additionally, diagnosing these cases can be challenging due to the similarity in clinical presentations. So biopsy and immunofluorescence, direct and indirect, are essential diagnostic tools to ensure accurate diagnosis. I'd like also to mention that in some cases, yes, the oral sign may be the first, maybe sometimes the only. As for the systemic lupus erythematosus, of course, the oral sign, the sign is in the oral cavity, even if it is at the beginning of the disease, we cannot have the diagnosis just only by the oral sign. We also need other systemic signs and symptomatology. I think that I haven't mentioned during our meetings for that round table that I had a young patient that we made the diagnosis from a red lesion in the palate suffering from systemic lupus erythematosus. But the importance in that case was not that that red lesion was indicative of systemic lupus, but the important is that all the other signs and symptoms that the patient presented months ago were neglected and did not noticed by the referral physician. So it is very important to hear carefully all the medical history and all the relevant information that our patient give us. So, Spiros, thank you again. And we will continue with the next presentation.
Yes, we
which
welcome
is
Anna Maina.
Christina Bell.
Yes, if it's possible to share the slides. Michaela.
I will do it.
It's Anna. Sorry, guys. It is Anna that will continue the presentation.
Okay, thanks. My name is Maina Anna. I am a fifth-year medical student, and I would like to thank the organization committee, our instructor, Dr. Smaragdi, and I apologize for not being in person. Today, I will present you an emergency case. And for the following case, I would like also again to thank Dr. Yamadi that provided us from her personal archive for educational reasons. So we have a 62 years old woman that comes in our office with skin lesions to the face and on her trunk, together with symptoms in the oral mucosa. But she doesn't report something significant from her past medical history, besides from the fact that she is under therapy with antibiotics, trimethoprim sulfamethoxazole, for a urinary tract infection. In the next slide, we can find our physical examination features. To continue with, our diagnosis was based only on clinical findings and no further examinations were performed. And we have a diagnosis, which is the so-called erythema multiforme due to the antibiotic. There is a variety of causative agents that have been reported in literature. A significant correlation exists between viral infections and erythema multiforme, particularly by herpes simplex virus infection. However, viral agents are not limited in HSV, as you can see in the first table. Moreover, bacterial infections are encountered more as causative agents of erythema multiforme major, which is one of the two categories that concern either respiratory infections or gastrointestinal system infections. For example, we have Mycoplasma pneumonia mucositis, which is commonly encountered in children. Sexual transmitted diseases, together with some hematological and solid organ malignancies, as you can see in the next slide, are also common triggers of erythema multiforme. A very, very important aspect of etiological factors are the medications. We should pay attention in this category, since there are different drugs that provoke erythema multiforme and different drugs that provoke Stevens-Johnson syndrome that we will discuss later. Regarding erythema multiforme now, sulfonamides are responsible in the majority, and they are given for common cold or flus. Obtaining a good and an extensive medical history from your patient is always the best tool for your diagnosis. If you suspect erythema multiforme from your clinical examination, that will be discussed later how we do it, you should ask always for a recent upper respiratory infection with symptoms like runny nose or cough for the past 1 to 5 days, or for any gastrointestinal symptoms that they last the last 14 days, or generally about fatigue, malaise, fever as constitutional symptoms. It is important to remember to ask these questions. Why? Because more than 50% of the patients have a prodrome of influenza-like syndromes prior to the mucosal manifestations that we will see later. Over-the-counter drugs or a newly drug administration should be also investigated because maybe the causative agents. And do not forget to ask the patient for any recurrent painful ulcer or lesion in the mouth, suspecting, of course, an herpes simplex virus infection. The questions above concern only the causative agents and the triggering factors, so additional questions should be asked regarding the symptoms and the course of the disease. In the next slide, we will try to categorize and classify this disease. We have two categories. The erythema multiforme major, that is characterized by cutaneous manifestations in the skin, accompanied by mucosal involvement, a significant mucosal involvement, and always accompanied by systemic symptoms. We have in this category always the systemic symptoms. In the contrast, in erythema multiforme minor, we have only cutaneous manifestations with absent or minimal mucosal involvement, and never we will encounter systemic symptoms. In the first two pictures, as we proceed in semiology, you can identify the characteristic concentric lesions that appear like an urticarial plaque that can be increased slightly up to 2 centimeters in the first 24 to 48 hours. A center small papule or bulla can develop and then flattens. An intermediate ring develops and becomes raised, edematous, and pale. The periphery then gradually becomes cyanotic, and this target lesion is developed, as you can observe in the second image on the right side. Sometimes lesions can be distributed at areas of previous trauma, the so-called Kebner phenomenon that my colleague Spiros also mentioned previously. So if you have a patient with these classical targetoid cutaneous lesions accompanied with blistering of mucosal areas, such as in the lips of the first image, as you can observe, you can diagnose the erythema multiforme major, which is characterized by both cutaneous manifestations and mucosal involvement, as we explained. In this case, we encounter a more atypical clinical appearance of the rashes. They look like raised with a non-defined border. If we have also absence or minimal mucosal involvement, it can be characterized this time as erythema multiforme minor. Regarding the previously discussed skin manifestations, it is important to note the distribution of the rashes only in a symmetrical manner, unilaterally, involving mainly the extremities, the extensor surfaces, and not the flexor surfaces, the palms, the necks, and the face. The soles are being spared. In the case of erythema major, systemic symptoms can present too. We said it multiple times from the beginning of the presentation. These depend on which mucosal site area is involved. The common case of oral mucosa can be presented as discomfort in swallowing either liquids or solid food. The next mucosal sites that we'll discuss now are less common to be involved, but if this is the case, then a conjunctival involvement may cause eye problems, such as extensive lacrimation or preference of dark rooms or burning eyes. If genitals are affected, painful urination is a common complaint from the patients, sometimes together with urinary retention. Last but not least, diarrhea and vomiting are encountered if ulcerations are on the gastrointestinal mucosa. Which is the next step after the clinical examination? Of course, forming a list with possible diagnoses for differential diagnosis. Further investigation should be performed if we are not sure, in order to rule out some of them and decide which is the correct diagnosis. As you can observe in this slide, a variety of diseases with cutaneous and systemic manifestations is listed. If a patient presented with a more extensive mucositis, then we should suspect either paraneoplastic pemphigus or even simple pemphigus vulgaris, graft versus host disease, and of course the big controversy, Stevens-Johnson syndrome and toxic epidermal necrosis, that will be discussed later. All these diseases are very important to be early diagnosed since they are life-threatening. What now if we had a patient with severe gingivitis, which is rarely seen in erythema multiforme? Then we should suspect better that we encounter a disease, for example, pemphigus vulgaris disease. To continue with, when the cutaneous involvement is sparse, mycoplasma pneumonia induced mucositis, but as an independent entity is being suspected. The best way now to confirm your diagnosis is, except from a detailed clinical and past medical history, or an accurate clinical examination of all systems, like a review, we should add in our investigations serological tests for mycoplasma pneumonia to exclude it, and PCR for herpes simplex virus infection, and of course a biopsy for histopathological examination, in combination with sometimes immunofluorescence studies. Now, the histopathological findings that we would ask for show a transition of basal keratinocytes to this keratotic one, together with vacuolar generation as a process of apoptosis. We count a great number of T lymphocytes, perivascular or along the dermatoepidermal junction, accompanied by many macrophages, as you can imagine, in terms of apoptosis. Subepithelial blisters, vesiculations, and papillary edema are observed but have no significance for us for now, as junior doctors. In contrast, direct immunofluorescence study is also an important diagnostic tool, but the diagnosis is mainly clinically made. And now let's speak about the Nikolsky sign, which is always negative in erythema multiforme. In other words, you will not see the redness of the skin with the fluid collection underneath that makes the skin to rub off, leaving a raw red base, as you can see in the third picture. This is a very helpful tool to differentiate erythema multiforme from Stevens-Johnson syndrome, this life-threatening disease that we'll discuss right now. In the terms of differential diagnosis, what should we suspect if we had to manage the following case? We have a 55-year-old man that he's under piroxicam, which is a non-steroidal drug, anti-inflammatory drug, for musculoskeletal problems and for arthralgia. He's also in PPIs for stomach complaints. And he's now on the ward for the last 3 days, for 3 to 4 days, with fever and also dysphagia, and he looks generally unwell. Do you manage the patient with the same way? Absolutely no, because there are some different points that we should pay attention in this case, like the fever or other systemic symptoms like dysphagia, together with spreading of the lesions in more than one mucosal site. However, still less than 10% of the total body surface is being involved. In the third picture, we can see the peeling of the skin, which characterizes the disease and leaves behind this erythematosus base. This is called denudation. Due to these differences, the diagnosis is not erythema multiforme in this case, but a different entity, the Stevens-Johnson syndrome, due to the use of non-steroidal anti-inflammatory drug. But what is Stevens-Johnson syndrome? It's a life-threatening disease and condition that is more severe than erythema multiforme major. It looks like a more atypical or macular lesions with pruritus, and then they are distributed all over the face and the trunk. We expect a greater involvement of less typical mucosal sites, for example, ocular or genitourinary tract, apart from the classic oral mucosa. Conjunctival scarring is a common sequel of Stevens-Johnson and of toxic epidermal necrosis. The important characteristic is the denudation, so the Nikolsky sign now is positive. Elderly are mostly affected compared to younger ages, that are involved in erythema multiforme, and moreover, a greater risk of patients with HIV infection or collagen vascular disease for Stevens-Johnson syndrome exists. Drugs are the main causative agents now, unlikely to erythema multiforme with the infectious etiological factors, but which is one big red flag that we should observe as junior doctors and make us suspicious for Stevens-Johnson syndrome, the toxic and the unwell appearance of our patient. It's a patient that comes in our office with constitutional symptoms like fever, sore throat, arthralgia, or myalgia. Now, between Stevens-Johnson syndrome and toxic epidermal necrosis, there are no big differences in the symptoms, apart from the greater percentage of total body surface that is involved. To revise, as you can see also in the picture on the right side, Stevens-Johnson syndrome has less than 10% body surface detachment, followed by an overlapping syndrome that has a range between 10 to 30%, and leading to a greater than 30% detachment of total body surface in the case of toxic epidermal necrosis. There is a big discussion surrounding these two diseases because erythema multiforme and Stevens-Johnson syndrome, because it is needed to be distinguished. And why is this important? The management plan will be different in each case. Hospitalization is urgent in case of Stevens-Johnson syndrome and toxic epidermal necrolysis, of course, in order to avoid severe dehydration and sepsis, which, as we know, are common causes of death. For this reason, the mortality risk is very high for toxic epidermal necrolysis, as well as the 5-year survival after an acute phase, which is decreased at 65%. In the next slide, we should pay attention to the fact that erythema multiforme is a self-limiting disease. Of course, as we do in medicine, in order to speed its remission, we will use except from supportive treatments such as analgesics or other supportive measurements, topical corticosteroids for erythema multiforme minor instead of systemic corticosteroids for erythema multiforme major. Studies showed also that cyclosporine is ideal for recurrent cases. In some cases, additional antiviral therapy such as acyclovir is given. In our case, as you can see in the next slide, we follow the management plan that we discussed right now, and so we have this excellent recovery. Thank you very much for your attention, and feel free to ask at the end any questions. Thank you.
So thank you, Anna, again for your insightful presentation. And the cases you presented offer a contrast in diagnostic methodology compared to autoimmune cases discussed by Spiros earlier. And unlike autoimmune diseases, the diagnosis of these instances based only on the presence of oral and skin lesions, eliminating the necessity for other diagnostic tests. And this highlights the crucial importance of possessing relevant knowledge in identifying and managing such conditions. And following the instructions by Daniel that we have to speed up, I will not mention any other comments, and we will proceed with our next presentation by, I don't know, Michaela or Christina?
Hello, my name is Christina Peru, and I am a 4th-year dental student. Before starting, I would like to thank the organizing committee of this Congress. The topic of my presentation is gingival hyperplasia as the first sign of systemic disorders. I will start with a case presentation. We have an 11-year-old female that attended the Department of Dentistry with the chief complaint of generalized gingival enlargement. In these photos, we can observe the maxillary and mandibular gingival enlargements. We will continue with the history of the lesion. The gingival enlargement started 1 month ago in the maxillary left posterior region, and over 3 weeks, there was a gradual generalized gingival enlargement in the maxillary and mandibular arches. She visited the local health center, but only symptomatic treatment was provided to the patient. The patient gave a history of mild fever, sore throat, fatigue, and weight loss. The clinical examination revealed gingival with a pale and bulbous appearance, with loss of stripling and focal hemorrhagic areas. Lymph nodes of the orophacial region were tender and enlarged on palpation, with no involvement of the cervical group of lymph nodes. The patient was on antibiotics and analgesic prescribed at the local health center before visiting the Department of Dentistry. Our next step in our clinical investigation was to perform blood tests such as complete blood count and peripheral blood smear. The results showed an increase in white blood count with suggestive of leukocytosis, decreased red blood count with lowered hematocrit and hemoglobin levels, and low platelet count. Peripheral blood smear showed immature monocytes. The patient was referred to the hematology department with the preliminary diagnosis of leukemia. Bone marrow aspiration revealed a hypercellular bone marrow infiltration of myeloblasts. The final diagnosis was acute monocytic leukemia. In this figure, we observe the resolution of hyperplasia after treatment was provided to the patient. Leukemia is a hematologic disorder characterized by the differentiation and proliferation of malignant leukocytes, which destroy the bone marrow, generating the multiplication of leukemic cells. It is categorized according to its clinical behavior to acute and chronic, and according to its histogenetic origin to lymphocytic and myelolytic. Acute myeloid leukemia is the most common type of leukemia in adults and develops quickly and affects myeloid cells, particularly the ones that would develop into white blood cells. It is a highly aggressive malignancy, and it frequently involves oral abnormalities. Acute monocytic leukemia is a subtype of acute myelolytic leukemia in which at least 80% of the affected blood cells are a type of white blood cells called monocytes. The presenting sign can be gingival overgrowth. The clinical manifestations of acute myeloid leukemia include unusual bleeding, infrequent nose bleeding and bleeding from the gums, lethargy and fatigue, fever, weight loss, bone pain, easy bruising, swollen lymph nodes, excessive breath, sweating at night, pale skin, and frequent infections. The oral manifestations include gingival hypertrophy, petechiae, ecchymosis, ulcers, and hemorrhages, especially spontaneous gingival bleeding. In these figures, we observe gingival hyperplasia as the first sign of leukemia. It is important to mention that over 30% of individuals who are diagnosed with leukemia experience these oral manifestations, and according to report, gingival enlargement represents a range 5 to 35% frequency as the initial presenting complication of acute monocytic leukemia. Differential diagnosis should include acute and chronic infections limited to the oral cavity. For example, periodontal infection or trauma tends to demonstrate erythematous and spongy gingiva localized to a focal area. Medication, such as calcium channel blocker, verapamil and nifedipine, the immunosuppressant cyclosporine, and the anticonvulsant phenytoin. Hormonal changes, such as pregnancy and puberty. Autoimmune disorders, such as sarcoidosis and Crohn's disease. However, the enlargement typically occurs before the age of 20, and neoplasia such as amyloidosis or lymphoma. For a final diagnosis, complete blood count is important in situations where the clinician suspects leukemia. Now we will continue with some other conditions that also represent clinical manifestations in the oral cavity and shouldn't be overlooked. Pernicious anemia is an autoimmune disease in which the body cannot produce healthy red blood cells due to the lack of vitamin B12. The classic oral finding is the presence of a painful burning atrophic tongue or bald tongue. Angular cheilitis may also occur in addition to alterations in taste sensation. Aplastic anemia is a hematologic disorder characterized by failure of hematopoietic precursor cells to produce adequate numbers of all types of blood cells, may appear as oral petechiae, spontaneous gingival bleeding, enchymosis, and gingival hyperplasia. Last but not least, thrombocytopenia is initially detected because of the presence of oral lesions. In a patient with thrombocytopenia, the thrombi do not form properly. This results in a leakage of blood from the small vessels. The characteristic oral findings are gingival bleeding as a result of minor trauma, such as bruising and flossing, and may be the first sign of thrombocytopenia. Other early signs include petechiae and ecchymosis on the soft palate or buccal mucosa. Purpura and mucocutaneous bleeding may result in hemorrhagic bulle. In conclusion, as we all previously mentioned, leukemia is a hematologic disorder with frequent oral manifestation. This case presentation illustrates the importance of including systemic disease in the differential diagnosis of gingival pain, bleeding, and hyperplasia. Close patient follow-up and re-evaluation of the working diagnosis is important if routine therapy fails to resolve the problem. Thank you very much.
Thank you, Christina. You have effectively underscored the significance of understanding hematological diseases in relation to oral health And for all of us, it is crucial to recognize that not all cases of gingival enlargement arise from gum diseases. Rather, they can serve as early indicators of serious hematologic conditions. And we will continue with the last presentation provided by Michaela Stoupi.
Hello everyone, I'm Michaela Stoupi. I'm also a fourth-year dental student, and I'm going to present you an interesting case, but I'm not going to reveal you the diagnosis since we can find out what it is through our discussion. Special thanks, of course, to the organizing committee of the Congress. Sorry. And of course, to our Dr. Diamanti, who provide us with these cases, and we can present to you. This is a case of her clinic. There was a female at the age of 69. She visited her clinic, and she was complaining about pain on the right side of the mandible, as you see. These are the X-rays that she provided. She supplied the doctor on different stages, and you see that we have a defect on the bone. The patient also had pain on, hyposthesia on the lower side of the lip. And this happened after the extraction of 3 teeth that she had on this region. But after the extractions, she kept having infections on the mandible. So after the panoramics, she did a computed tomography, and this showed that we have an osteolytic lesion with large bone sequestra. The patient also was under the treatment of osteoporosis and rheumatoid arthritis, and this is a hint for you. And she was also taking oral bisphosphonates. The doctors, Dr. Diamanti and the team, provided her with amoxicillin and clindamycin for 2 weeks each, and chlorhexidine mouthwash, of course. So 4 weeks later, you see the difference on the marked area, and this showed the area of hyposthesia. So in the first, actually in the third photo, you see the beginning, and in the fourth photo, you see 4 weeks later. After the medication. In the first photo, you see that we have the bone exposure in the oral cavity, and on the second photo, you see that we have the pus coming out after the pressure from the doctor. So what we reveal that we have medication-related osteonecrosis of the jaw, also called MRONS. According to the American Association of Maxillofacial Surgeons, is a serious complication that can arise in patients who took or are taking antidisruptive or anti-angiogenic agents, leading to visible bone or fistula that continues for more than 8 weeks without any history of radiotherapy. The same association classifies the MRONS into 3 stages, but in order to do that, we have to ask ourselves, what is the most important question to ask ourselves is, do I probe the bone? If I probe the bone, even if we have the exposure of the bone in the oral cavity, even if it's the whole maxilla, it doesn't matter. If we probe the bone, it's stage 1. If we probe and we have pus, it's stage 2. If we probe, we have pus, and the most characteristic sign, we have extraoral fistula, then it is stage 3. This is the most simplified way to identify them. Here you see stage 0, we have no symptoms. The patient doesn't have any symptoms. Stage 1, we're probing the bone. Stage 2, we see the pus. Here you can see it. And stage 3, we have the extraoral fistula. There are some diagnostic criteria that can help us. There is a marker, the C-terminal telopeptide, that measures the bone turnover. And this comes for the collagen type 1, but there is not enough evidence that this marker can help us to predict that we can have MRONS, although it can be a predicting factor. I know it's a bit controversial, but you know what I mean. We proceed with the risk factors, which are the most interesting part, regarding the drugs that we have in these cases. You know that the medication-related osteonecrosis of the jaw is a major problem that can occur in patients that are taking medications in order to treat osteoporosis, prostate cancer, or metastatic cancer. And the most common is the bisphosphonates. But the people who are taking them in an IV mode, there are higher chances of developing MRONS instead of those who are taking them orally. And the medication zoledronate is the most potent in between the bisphosphonates. We proceeded with the denosumab, as you all know. Even though it seems to have several advantages over the bisphosphonates, like superior prevention characteristics of skeletal-related events or subcutaneous management instead of intravenous administration without any dose adjustment in case of renal impairment. On the other hand, there are some studies that have shown that it can lead in higher chances of developing bronze. So there are some positive and negatives in its medication. The most common meds that are used are the Xgeva and the Prolia. Both of them are administered subcutaneously, but the Prolia is administered every 6 months and Xgeva every 1 month. There are other drugs that can cause also osteonecrosis, like the anti-angiogenic, that inhibit the development of new blood vessels, which can result in osteonecrosis of the jaw through ischemia. And they're used to prevent cancer metastasis across the blood vessels and lymph nodes. The last one medication that we'll refer is the tocilizumab, which is used for the management of rheumatoid arthritis, and there are some studies that have shown the relation between this medication and bronze. Other important risks that play a crucial role in our topic are the dental disease and dental procedures. Previously existing inflammatory dental conditions, including periodontal and periapical disease, the use of dentures and the existence of dental abscesses, and the inadequate oral hygiene or the implants are very important risks. Older females who are who are in postmenopausal period of their life and are in higher risk of getting bronze, and it is more prevalent in the mandible. Regarding the medical factors have been reported: the chemotherapy, corticosteroids, smoking, breast and prostate cancer, multiple myeloma, renal dialysis, diabetes, and hypothyroidism. The last risk is the genetic factors. There is a gene, the matrix metalloproteinase 2, that was hypothesized to be a possible gene factor for elevated risk of getting bronze. We proceed with the prevention before the anti-resorptive therapy. The patient, of course, before starting the anti-resorptive therapy, has to visit the dentist for a full oral examination and follow the oral hygiene instructions that the dentist will show. The dentist, from his side, has to educate the patient about the chances of getting osteonecrosis and the symptoms and the signs. Of course, before any surgical treatment like an extraction, he has to be in contact with a prescribing provider. And cases where we have patients with, who are under IV anti-resorptive therapy or cancer therapy, they're considered to be contraindications for any dental surgery. Here we reach the point of the black hole, where I cannot answer these questions if we have to follow the drug holiday. There is not enough evidence to support that the drug's holiday's efficacy, so each time the dentist should be in contact with you, the physicians, and follow specific guidelines. There's another question for you guys, that do you think that there are other guys that can cause osteonecrosis? I would say yes, because there is another case report where the patient was taking infliximab in order to treat Crohn's disease, and it was related with osteonecrosis of the jaw. The infliximab is an anti-TNF-alpha antibody, was generally used for Crohn's, rheumatoid arthritis, ulcerative colitis, ankylosing spondylitis, psoriatic arthritis, and plaque psoriasis. So we can say that the list of the drugs is broader, and we can add new medications, medications in that. Here we will continue, as we're reaching the end, the case that I showed you in the beginning. Dr. Diamati raised the flap, she exposed the necrotic bone, removed all the necrotic bone until she reached the healthy bone. She used the PRF plasma-rich membranes in order to achieve a better soft tissue healing and without exposing any bone in the oral cavity. She did sutures in order to close the wounds. And here's the result that you see 2 weeks later, and in the second picture, 8 weeks later. You see the results are amazing. And this is the last panoramic that was taken. You see that we have only healthy bone in the mouth of the patient. So to conclude, as I said before, the group of people that are in greater risk are the postmenopausal females, so they're taking the medications in order to treat osteoporosis. So a collaborative approach, including dentists, physicians, and pharmacists, is deemed to be critical to preventing the development of MRONs. So thank you very much for your time and your attention. I hope you like our presentations.
Michaela, thank you. With your presentation, you have highlighted the crucial role that the dentists may play in prevention, early detection, and management of medication-related osteonecrosis of the jaw. So staying informed about the conditions, risk factors, and symptoms allows dentists to provide optimal care for their patients and minimize the risk of complication associated for this condition. Regrettably, as I am informed, there is no time for discussion as the next roundtable is set to begin. So I would like to extend my gratitude once again to the students of medical school, Spiros and Anna, and my beloved students from dentistry school, Daniel, Christina, and Michaela, and of course, all of you for your attendance and participation. Have a nice day.
Thank you so much, Doctor, and I would like to conclude our session and to invite the next roundtable.
Okay, well, hello everyone. Thanks for being here. Now we're going to move on to our next roundtable. So please welcome the coordinator of this roundtable. Thank you.
Hello, good morning. Nice to see you. The topic of that neurosurgery session will be intracranial hemorrhages. So we are talking about urgent cases in neurosurgery. All the students have done wonderful work. So let's proceed and listen to them.
Good morning, everyone. My name is Marius, and today I'll be introducing this roundtable of neurosurgery with my presentation about aneurysmal subarachnoid hemorrhage. These are the points I will be focusing on. So let's get started. The arachnoid matter is a soft translucent membrane that loosely envelopes the brain. It is one of the meningeal artery, of the cranial meninges, and specifically it's the middle one. Above it we have the dura mater, and below it we have the pia mater. Today we will concern ourselves with the subarachnoid space, which is below the arachnoid mater or between the arachnoid mater and the pia mater. There we have the arteries, the veins, and the cerebrospinal fluid. Yeah, that's unexpected. So now for the circle of Willis. It is an arterial ring responsible for the blood supply to the brain. Specifically, it connects the anterior circulation of the bilateral internal carotid arteries with the posterior circulation of the vertebral arteries. The circle of Willis is characterized as an anastomotic connection of the two circulations. Its main function is to provide collateral blood flow between the circulation, thus protecting against ischemia in case of a weak vessel. Here in this picture and this MIP angiography, I want to point out some specific vessels that usually we have aneurysms. These are the anterior communicating artery, the posterior communicating artery, the middle cerebral artery, the basilar, and the internal carotid. So now, what is subarachnoid hemorrhage? It is a bleeding in the space between the pia mater and the arachnoid mater. And the situation usually develops like this. We have a burst or leakage of a weak blood vessel, and as the time passes, more and more blood builds up inside the subarachnoid space. So what do you think happens when a high-density fluid like blood takes the place of cerebrospinal fluid, which has its density close to that of water? Exactly. We have increased intracranial pressure, which is extremely dangerous since it can cause brain cell damage, prolonged complications, or even disabilities. Now, I want you to pay attention at these two CT scans. On the left, we see a normal one. And I want you to notice how the salcine fissures are black. That's because they are filled with cerebrospinal fluid, which, as I mentioned, is a hypodense substance. So let's think it like that. The darker these areas are, the better. Now, I want you to look at the one on the right, the subarachnoid hemorrhage scan. And do you see the problem here is that all these areas that were supposed to appear black, they appear white. They appear white. That's because they are filled with blood, which is hyperdense, which is a hyperdense substance. So now that we have a common basis, let's move a bit deeper. Let's talk a bit about its frequency. Subarachnoid hemorrhage is responsible for 10% of hemorrhagic strokes. By observing this map, you can see that I have marked Finland and Japan with red. That's because they have the highest rate worldwide, with approximately 16 cases per 100,000 people. But what about the centers of Western medicine? We have Europe with 11 cases per 100,000, and North America with 10 to 14 per 100,000, but lately there have been some studies suggesting 5 to 10. But what could cause a subarachnoid hemorrhage? The most common risk factors are bleeding disorders, inherited conditions, and social history, like alcohol consumption, tobacco use, and cocaine. The most common causes are either traumatic, and specifically we're talking about high-energy traumas, where in the case of young adults, those are car accidents, and for elderly people, falls, and about aneurysms. And from this point on, we will be focusing on them. So, an aneurysm is an abnormal bulge or ballooning in the wall of a blood vessel. It can have a circular or fusiform form, and it's the result of pressure on a weak area of the vessel wall. The problem with it is that we have bleeding inside the body, which may come unnoticed. The number speaks for themselves, since 13.5% of the cases lead to death. Now, here we see two techniques that we use to visualize the circulation is the DSA angiography and the CT angiography. The DSA is a fluoroscopic technique that captures continuous images and uses complex computerized X-ray machines. And the CT angiography, which combines a CT scan with an injection of a special dye to produce pictures of blood vessels and tissues. And you can see that these techniques make it really easy to locate the aneurysms. So, as I mentioned before, the middle cerebral artery is one of the vessels of interest, since it's the most frequent site for intracranial aneurysms. It is associated with 30 to 50% of them. And middle cerebral artery aneurysms usually have a broad base with several branches. And we should focus especially at the MCA bifurcation due to the fact that 80% of MCA aneurysms occur there. Thankfully, 40 to 50% of rupture MCAAs with intracranial hemorrhage present on the initial scan. Here we see a large hyperdense rounded lesion in the frontal region. Simply put, it is a massive middle cerebral artery aneurysm. Now for the symptoms. The most characteristic is the thunderclap headache, which is usually described as the worst headache of my life. And it is accompanied by nausea, vomiting, or photophobia. Other really common symptoms are neck pain, due to the fact that we have blood moving down the spinal cord, and the patient might also come in a comatose state that in some cases can be reversible. Even in an unruptured aneurysm, due to the increased intracranial pressure, the cranial nerves 3 and 6 can be compressed, causing oculomotor and abducens nerve palsy, respectively. Other symptoms could be seizures and convulsions, which are two different things, and there can also be stroke-like symptoms. Further possible complications could be hydrocephalus, due to the build-up of fluid in the ventricular system, or even inability to circulate the CSF because of blood clots. There's also vasospasm, which is narrowing of blood vessels, resulting to limited blood flow to the brain, which could cause ischemic stroke. And finally, a second rupture. The aneurysm may rupture again due to fragility of the vessel, and in this case, it can be extremely difficult to treat than it already is. And now that I've spoke about treatment, let's see a bit about that. So, first, we have to diagnose it. We either use MRIs, lumbar punctures, CTA angiographies, or DSA angiographies. And in case the diagnosis is positive for aneurysmal subarachnoid hemorrhage, the patient must be hospitalized immediately. So, inside the emergency room, our main goal is to stop bleeding and prevent rebleeding. During the ABCD assessment, we should prioritize, regarding airway and ventilation, to securing the airway, and the oxygen saturation must be around 96% or higher. Regarding rebleeding prevention, we have to control the systolic blood pressure, since more than 140 can lead to a rupture of the aneurysm. Regarding the initial resuscitation, we have to establish euvolemia, which is a state of having normal volume of blood or other fluids in the body, and the electrolyte deranged correction. And finally, nimodipine administration, which is a calcium channel blocker that is used to manage the systemic hypertension, and it is restricted only in managing vasospasm following subarachnoid hemorrhage. Now, regarding the medication, it really depends. For rebleeding prevention, we must focus around blood pressure medication, since it must be high enough for sufficient blood supply and low enough in order to not rupture the aneurysm. An example is nimodipine, as I said. There is also the seizure prevention, where we use anticonvulsants, and in case, if we want to prevent sickness and vomiting, we use antiemetics. But never should we administer anticoagulants and aspirins, since they could make the bleeding a lot worse. In the case of aneurysmal subarachnoid hemorrhage, the only option is an invasive procedure. Our main goal is to isolate the aneurysm or support the walls of the weak vessel. It should be performed in less than 48 hours after the rupture, and the most common procedures are endovascular coiling and microsurgical clipping. So I'm going to talk a bit more about this. Endovascular coiling. In this case, the neurosurgeon or the neuroradiologist inserts a catheter into a groin artery, and they advance it into the affected brain artery where the coil is deployed. The coils are tiny, soft platinum, spring-shaped metals that form mesh-like structures inside the aneurysm. In some cases, stenting might also be used alongside coiling in order to support and secure the placement of the coils inside the aneurysm, as you can see in the picture. This is a fluoroscopy-assisted procedure. Here, I have prepared this video where we can see a basilar artery aneurysm, and I decided to use this case specifically because the basilar artery is in a critical location that it's really difficult to access. So the only real option is to access it endovascularly. And here we see a DSA angiography after coiling treatment. And now for microsurgical clipping. This technique focuses on cutting off the blood supply to the aneurysm in order to prevent rupture and control the bleeding. In order to establish access to the brain, a craniotomy is performed. After that, a small metal clip is placed across the neck of the aneurysm, and it remains there permanently. Here we see a DS. Okay.
Sorry. Sorry, guys.
Perfect. So we apologize for the short break. We had the most scary situation with the fire alarm, but everything is now good. We'll now continue with the first speaker as we were doing before. So you can come and continue.
Happy times, happy times. So here we see a DSA of a right internal carotid artery with an absolutely massive aneurysm with a 16 millimeter fundus and a 5.4 millimeter neck, according to the case. The reason why I chose to show this case is because it's a really good example why we use clipping. Because here, due to the large neck of the aneurysm, it's really difficult to use coiling because it can be really easy for the coils to go out of the aneurysm and basically kill the patient. And there is also the reason because it is in the internal carotid artery, it's really easy to access through craniotomy. And here on the left, we see the clipping of the internal carotid artery, and on the right, we see a different case, but I wanted to show it to you because we can see clearly the craniotomy marked with blue. So, the pros and cons. On one hand, we have endovascular coiling, which is less invasive, safer, and has a shorter recovery time. However, as we saw, some aneurysms cannot be treated with it, and there's also a blood thinning therapy that the patient has to undergo after it, and it is relatively new. And even though it is a mild invasive procedure, we still use general anesthesia. On the other hand, we have microsurgical clipping, which is an established and safe procedure and can treat most aneurysms. It has a lower risk of recurrence. However, it is a highly invasive procedure, and this has its own risks. And obviously, we have to use general anesthesia. And the patient might require a longer recovery time that can go even up to months. So, the outcome. Even though the survival rate has increased the past years, there is still a 40% mortality rate, and even if someone survives, 1 out of 3 cases is severely disabled. And some of the complications that can have is a cognitive dysfunction, physical, speech, or emotional difficulties. Now, regarding the recovery of the patient, it can take a minimum of 3 weeks, and it can span up to several months. So, take-home points of this presentation. Both aneurysmal and non-aneurysmal subarachnoid hemorrhages are a medical emergency. In case of a severe headache, the best next step would be to seek medical help. And when we choose treatment, because it is such a dangerous case, there must be a mutual decision between the patient and the doctor on how we proceed. And whatever the outcome, the patient must undergo a prolonged follow-up that can take up to 5 years or even more. And the most important thing, a healthy lifestyle. You have to treat yourselves better. And with this, I come to the end of my presentation. This is my bibliography. And South Park is always right. Thank you for your time and attention. And now I'll be giving my spot to Johnny. Oh, Pauline.
Okay, so hi guys. I'll be now talking about the epidural hematoma. So I'll start with some anatomy since I think it's required in this case. As we can see in the picture, we do have the scalp, then we do have 3 meningeals, as we know. The dura, the arachnoid, and the pia mater, I'll show them now, as you can see here. So between the skull and the dura here, we have the epidural space, and then between the dura and the arachnoid space, we do have the subdural, and then between the arachnoids, then we have the subarachnoid space, which is obviously generally filled with the cerebrospinal fluid. So before we go into more details about what happens, what are the clinical features, we do need the Monro-Kelly principle. Why? Because obviously it's a physiological principle that states that the sum of the volume specifically of the blood, of the cerebrospinal fluid, along with the brain within the cranium are supposed to be constant. So to have a dynamic relationship. Obviously, there is an increase. Normally, we do have an increase, so we can compensate, and it goes like that. So now the etiology, as you can see in the pictures, we do have the pterion, which is basically the thinnest part of the temporal bone, and then we can see the middle meningeal artery, which is having a branch, the anterior branch more specifically, that goes below, branches below the pterion, which is basically due to usually a traumatic injury. So we tend to see specifically epidural hematomas in younger patients when they have a trauma, either when they're doing a sport or during an accident, essentially, which will lead to that. So more importantly, the clinical features of what we're supposed to be seeing. We do have a classic triad. First of all, we have the loss of consciousness. I think it makes sense. It's a hematoma in the brain. And then it's going to be followed up with a lucid interval, which means that the patient basically will be more or less normal again with their consciousness. And then we see again a decline neurologically. What does that mean? That could lead to different specific symptoms. We go from elevated intracranial pressure, we go through pupillary abnormalities to fixated dilated pupils. So these obviously vary. You can also see fractures, of course, since it is the most common cause, along with urination syndromes. More specifically, though, it would be good to keep in mind that we can have the Cushing triad. What it is basically having hypertension, having just difficulty with breathing, along with a patient that has really low pressure as well. So based on that, then you can see how the patient is presenting. Then we go into CT, which we use specifically CT without a contrast to diagnose a patient. We have two lovely pictures here. So you can see obviously here the hematoma, and you can see the midline as well. What we tend to usually see is that the hematoma is not affecting at all the sutures, but it is affecting the midline. We can see usually a shift to the midline, and then obviously you can see the hematoma, the shape as well. It is known as the lens-shaped. And then based on that, you could basically more or less identify that someone is having an epidural hematoma. Again, findings. This is also more easy for everyone that is not familiar with a CT. You can see here the midline. Again, the bioconvex hypertensity. You can see also obviously that the hematoma is located in the temporal bone, usually near or under the bone more specifically. And again, you can see that the sutures are not being affected, but only the midline. And here is the lens-shaped hematoma. So treatment. Of course, it is an emergency you need to run as a surgeon. The main aspects of what you need to do is obviously try to see the primary survey, how the patient is presenting, and of course, initiate immediately the neuroprotective measures. We need to obviously, first of all, stabilize the patient. That's really important. Also manage the increased intracranial pressure as well, and then of course, evacuate the hematoma. Obviously, you do expect to have a deterioration in the patient, then follow a lucid interval, and then of course, when you see that, you obviously need to rush into not delaying the initiation of treatment, because that would be fatal for the patient. So procedures. Obviously, the first one, as I said here, is a craniotomy. It can also lead then to evacuation of the hematoma and then the ligation of the vessels. Usually it could be the middle artery. And then you can also proceed with the burn holes. As you can see in Gray's Anatomy, I think is really common, and everyone knows about it, which is the skull definition more specifically. You could see here the burn hole as well. So essentially, in this case, when treating, you need to obviously have a neurosurgeon there help you assess the situation, and based also on the Glasgow Coma scale, decide on what's the best approach when it comes to treating the patient. Thank you very much, and I'll now pass it on to Johnny.
Thank you for joining the most interesting roundtable together with neurology. I'm going to talk about the subdural hematoma. I'm going to go through the types, the epidemiology, the causes, the clinical features, diagnostics, treatment, and outcome. So Marius showed the subarachnoid hemorrhage. Paulina showed the epidural, and I'm going to show you the subdural hematoma. So what is about? Subdural hematoma is a hemorrhage into the intracranial subdural space, right here, which happens between the dura mater and the arachnoid space. And due to the accumulation of blood, you can see here that the brain tissue is compressed. And then we will explain later on what's going on here. So about the epidemiology of the subdural hematoma, the incidence in the US, mostly we have data US and EU, but data are more in the US you can find more easily information, up to 17 per 100,000 child years. Lower than, below the 2 years of age, we have 13 per 100,000 child years, where below 1 year, the risk is much higher, and it can reach the number of 21 per 100,000 child years. So children and actually babies are more prevalent. In teenage years, it favors the male, and in general, it favors the male. Like you can see here, the 3-to-1 ratio, like 3 male, 1 female. And this acute subdural hematoma is more common in younger adults, and from the 30 to 50 years of age. Now, what causes the subdural hematoma? When we have a rupture of breaching veins that connects the superficial cerebral veins and meningeal veins, and the dural venous sinuses here. So here you can see the breaching vein being ruptured between the subdural space, and then here we have the accumulation of blood and increased pressure in the scalp, in the brain. So here you have the normal anatomy, what is normally happening, and then we have the rupture of an accumulation of blood. Here you can see the accumulation again of blood in the subdural space, and here you can see a CT scan with accumulation of blood. Here again accumulation of blood, the dura mater, the subdural hematoma, and the pressure like increased in the ICP. So the acute subdural hematoma, it usually happens in young people when they have an accident, head trauma, in older people in fallings, and in babies in non-accident trauma, and usually due to acceleration, deceleration injury, like mostly accidents. And here again, subdural hematoma, and you see here the midline shift and the accumulation of blood. So about the clinical features of the subdural hematoma, when we have an accident, the accumulation of blood happens immediately or right after the event, like within 2 to 3 days. We can have a rapid progression and can cause cerebral herniation and death. Cerebral herniation is when the intracranial pressure increased. So we have increased pressure of the brainstem, and as you probably most of you know, we have problems with breathing and the vitals of the patient. So what can cause? Like it can cause impaired consciousness, confusion, rapidly deteriorating to coma, Glasgow Coma Scale, focal neurological signs like ipsilateral hemiparalysis in one part of the body, cranial nerve pulses, can include diplopia or vision complications, increased intracranial pressure, headache, vomiting, and other complications. Now, how can we diagnose subdural hematoma and any other type of hematoma? We can use a CT head scan to diagnose like acute bleeding. We can see the crescent shaped homogeneously in the brain. It's something we can see later on. We see the hypertense area, something Marius showed also. The hypertense area is an area where it's shown in light gray color. We have diffusion over the affected hemisphere of hematoma, and up to 40% of subdural hematoma are mixed hyper and hypodense area, like gray, light gray and dark gray color. Unfortunately, in the MRI, which is my favorite diagnostic tool, is not usually used in acute cases, but it can actually identify cases of bleeding, like for example, chronic bleeding, malignancy, strokes, and any other disease of the brain. Now, with the CT scan, you can see here in the right acute subdural hematoma, causing like a mass of blood. We can see the midline shift right here. And then we can see the left ventricle being trapped. And this can cause the increase of intracranial pressure. And then you can have, as we said before, a problem with the brainstem or any other parts of the brain. Here, it's again the subdural hematoma, the blood accumulation between the dura and the arachnoid mater here. And then this is what I described before, the crescent-shaped hematoma. You basically see that the hyper accumulation of blood, and it usually have this shape. You can see it here. So what do we do about it when we have subdural hematoma? That depends on the size of hematoma, the neurological status, the etiology. Most of the cases we need immediate immediate neurosurgery consult, like operation, and the intervention should take place within the 4 hours, if it's acute, of course. So, where do we intervene and when? We intervene neurosurgically when the hematoma is equal or higher than 10 millimeters, when you have a midline shift of higher than 5 millimeters, and when we have a rapid neurological deterioration, and we have a unilateral, bilateral fixed dilated pupils, when the intracranial pressure is higher than 20 millimeters. And usually we do that within 4 hours of the incident, of the accident. So when we have cerebral herniation, we need the emergency craniotomy. This is what we do to decompress the brain. So we remove the skull, we remove the bleeding, so the brain can decompress and decrease the intracranial pressure and put the midline in the middle, actually. We decrease the ICPs. Anyone interested in the neurosurgery? You're gonna love that. So what we do, I'm gonna go through it. We do a skin incision, then, that's, by the way, description, we don't do it in detail. We do a skin incision, we do bar holes here, and then you can see where the skull will be detached. Then we cut the skull here, and then we have the skull bone removed. We use suction to remove the blood of hematoma. And then when everything is according to the plans and protocols, then we have the dura here sutured. We put the bone plate back to the skull. We use some techniques here for the attachment of the skull. Then we have the scalp incision closed with staples here. And then we use drain to remove any liquids from the brain, usually 24 to 40 hours, I think. Here's a real scenario. Like we can see the removal of the skull, the hematoma, the holes. Here's the hematoma. Remove the bleeding, and then we put the skull back and continue with the procedure. So, in subdural hematoma, if there are no complications after the surgery, patient can leave the hospital after a few days. If there are complications, the patient can stay several weeks in the hospital, and then the recovery actually varies to, as I said before, the type of accident, the etiology, the neurological status. Usually there's a follow-up appointment for evaluation. And subdural hematomas are often benign, and the mortality can reach to 50 to 90%, especially to people like getting anticoagulants. And from the people getting anticoagulants, only 20% will recover. So you can imagine if there is a hemorrhage and then you take anticoagulant, then exactly, you have a problem. Here is my references. Thank you for your attention. And we're open to questions.
Thank you all for the high quality presentations. I don't know if you want something to ask or any questions or something was a bit blur and you want to discuss it even further.
Yes.
Congratulations on the beautiful presentations. I have a question on Mario's topic. I wanted to ask if you know which one of the types of aneurysms are more vulnerable on rupturing, the circular one or the fusiform one, if there is such data?
From what I've researched, the circular one, or also known as berry, is more prone to rupture because it's that the form of the aneurysm that the pressure to the vessel wall is a lot higher than in case of the fusiform, where it is more balanced and it's put throughout the whole aneurysm.
Virtually, the fusiform aneurysm is a dilation of the vessel itself, while the berry aneurysm is a focal weakening of the wall of the vessel, and that makes that balloon-shaped aneurysm prone to rupture, while in the fusiform aneurysms, there is, for a short length of the vessel, a dilation. It's not, some do not consider the fusiform aneurysm proper aneurysm. Still, there is the possibility for a rupture, but it's lower compared to the berry aneurysms.
Thank you.
Other questions?
For Johnny's presentation, I would like to know what is the specific reason of making the burr holes before you start opening the skull fully?
As far as I know, is to make the skull removal easier, and actually you make the holes in most of the cases, and Dr. Faropoulos can correct me, in chronic subdural hematoma, like one hole, like to remove the blood. But for acute, I think they do the holes to make it easier for the skull to be removed. Dr. Faropoulos?
Yes, so it's a technical question. We have to find a way to open the skull safely. During the past, there were many ways to do that with trepanation or something like that. What we do now is first to open the holes, and then we use a saw in order to cut the bone, in order to create a window. Somehow, we have to start from somewhere. You cannot place a saw directly in the skull in order to cut the bone. Nowadays we have the drill. Virtually it has two circles. The inner one, it's more like a filler, and the outer circle cuts the bone. And when the first part of the drill, the inner part of the drill, feels no pressure, it means that we reach our target, and it stops the entire machine. It stops the outer circle, so it stops the drilling. Otherwise, especially if we did not have that device, there is a danger to get with the drill inside the head. Even with that protective mechanism, you can still enter with the drill in the head of the patient. I was present in one scenario. I was not using I remember I was a trainee, a senior trainee, and I gave the junior trainee the drill to perform the burr hole. I don't know, perhaps he was over enthusiastic about that procedure, and he entered with the drill inside intracranially. Thankfully, we are talking about an hematoma, so he gets inside the hemorrhage. So what you have to keep in mind is that, okay, you have to press a bit, but you are not 100% safe. And it's a modern technique. I mean, 20 years ago, the idea the way to cut the bone was again to try with a trepanation with no protection to open two burr holes, and then they tried to pass a tiny saw, a tiny wire saw, and then they used to cut the bone this way. They pass that saw from one hole to the other hole, and you attach it to two handles, and then you cut the bone that way. We're talking about ugly and dangerous stuff, but now we have more sophisticated equipment.
Thank you very much.
You're welcome. Welcome. Any other question? probably for my fifth or sixth year.
So let's conclude that round table. Thank you all.
Thank you, everyone.
So now we're going to go for a quick break for the live stream as well. So we'll see you in a bit for the next workshops.
Hello, Fatima, can you hear us?
Hello, yes, I can.
Okay. Can you show the presentation, or do you want me to share it with?
I think if I can share the screen, that would be better.
Mm-hmm.
Do you see it?
Yeah. Can you make it full screen, please?
Yeah, just a second.
Great. So our next presentation is Fatima Jamal, and she will talk about residency in Norway. Thank you.
Yeah, okay, so hello everyone, my name is Fatima. I am a EUC graduate from last year, actually. I graduated 2023. I'm currently based in Norway. I am Norwegian, born and raised here, but originally from Yemen. So it only makes sense for me personally to come back to Norway. So I'm going to be talking to you about my pathway or what I'm currently doing. And yeah, if you have any questions, feel free to ask. So how it works basically, first you finish university, apply for the medical license, the Norwegian medical license. And with that license, then you can apply for residency or work. And then the goal is to get into this one. It stands for Lege i Spesialisering, which means doctor in specialization. It's mandatory. You can call it compulsory service. It's 18 months. And then once you're done with this, then you start your actual specialization with at least 2 or at least 3, depending on what specialty you end up choosing. It is a relatively straightforward process, but unfortunately, there's no way for you to arrange at least one position alone unless you just follow this, what I'm basically going to present to you all. If you're Norwegian, I recommend you apply for the student medical license. It's the studentlicens. This you can apply for in the 5th year, actually. As soon as you finish 5th year, apply for it so you can maybe get like 3 weeks or even a month worth of experience. Or once you graduate, at least you have a license to work with whilst you wait for your actual doctor license. Basically, total specialty minimum is 6.5 years. It is 6.5 years because 1.5 is the compulsory service, the list one, and then 5 years minimum for your actual specialty. And I believe that is GP, that is the shortest, if I'm not mistaken. Then the rest just depends on whatever you choose. So as soon as you finish university, my recommendation is truly just to gather all of the important documents, of which include the letter of conformity. Get this the day you get your diploma. You get this from the Ministry of Health. This is next to Syrian Friendship Club, if you guys know where that is, the restaurant. And I recommend also getting the police clearance. Make sure you have 20 euros cash with you because they don't really accept a bank card. And I know I used this, I submitted this paper, but I do not actually remember to what I submitted it to, but I know you need it, so get it. Right after, apply for the license. And I recommend doing it immediately because the processing time is 3 months, actually. You apply through, or the information is posted on the Helsedirektoratet, which is the health directorate in Norway. And you can, through this website, gives you extra information. You log in through Alt-in. Through Alt-in, you use if you're Norwegian, you use your national ID number, the 11-digit number, plus your bank ID. If you're not Norwegian, you can log into Alt-in using the alternative login to Alt-in. However, you will require a scanned copy of your passport or European ID card, and it's very important that your application uses the same name as your passport, otherwise it will be declined. This website has more information, actually. It's the Helsedirektoratet website with everything posted. The documents you will require is your diploma in English. It is already in English. Transcript, letter of conformity, and if you have a medical license in a different country, then you will need a current professional status. It's a CCPS. You can request this from your, I think, directorate. I'm not so sure. But that's if if you have a medical license or if you practice your profession in another country, basically. Do you need to take an examination? No, because EUC is EU and EEA recognized, approved already, and you just have to pay the processing fee of 1.6K. That is maybe the equivalent of $150, something like that. And the processing time is just 3 months, as I've mentioned. So the residency application, it's through Web Recruiter. You actually do not have to wait till after you graduate to apply. My recommendation to those in 6th year, I mean, it's already passed for those in 6th year, but if you're wanting to apply and you're in 5th, apply in January whilst you're still studying, because although you're obviously, or not obviously, you will you're more likely to get a refusal, get a decline, but you've already applied, and in the application, residency application, there are several questions that you need to answer. And one of them asks you, how many times have you actually applied, or how many rounds of applications have you gone through? So if you already have one and you got a refusal the first time, then the second time you're going to apply, the more likely that you're actually going to be accepted. Anyway, so the application times is 2 times a year. You can apply the semester before graduating, as I just said. There is one in spring. There's a spring application, which has already passed. It was in beginning of January, end of January, beginning of February, and it is to start working in 1st of September. The next application time will open in autumn. It is in August, end of August, beginning of September, and you will start working in 1st of March if you actually get it accepted. The application process is the same throughout the whole entire country. You will require some sort of language certificate if you are foreign, even if you are Norwegian. If you haven't graduated from Norwegian videregående here, high school that is, then you will need some sort of proof of Norwegian. B2 is minimum. However, if you go more up north, then it's most likely that you will need C1. I know in Bergen they require it, and the more north you go up towards Trondheim and these smaller villages, because of different dialects and whatnot, then yeah, C1 is required or advised to have. You will need a visa, rights to work. If you're Norwegian, your passport is more than enough. But if you're a foreigner, then you do require a visa. I don't have any information about that, unfortunately, but you can for sure search it up. In the application, there are a few things that you actually have to fill out. There are some documents that need to be uploaded, including your CV. Your CV, all the documentation needs to be in English, in Norwegian, and you want to include your work experience. So any work experience that you have, even internship, these count. Language certificates, not just Norwegian. English is great. If you're Greek, get a Greek certificate or something just to show that you speak something to prove that you speak more than one language, basically, apart from Norwegian, if that is. Your doctor's license. Some places actually require a driving's license. So if you haven't got that sorted, I advise you do so. It's very easy to get in Cyprus. And if you get it in Cyprus, you can easily get it transferred or approved here in Norway. The system is very easy since it is an EU license. So you will also need to upload your diploma, letter of conformity, and your transcript, and any relevant certificates. Maybe you've done the ILS, maybe you've done the ATLS, ALS, and whatever certification actually helps. I personally put up my CAMeSM certificates as well, and it is something to add. The more the better, just make sure that it's actually relevant. So as I said, the documents that you will actually be required to upload is, the part of the application is the documents, and then there's actually something called the søknadstext, which is your application. I forgot the translation, but the text for you to actually apply. Basically, you write something to convince them to hire you. The selection process really just depends on the relevant medical experiences, internships, if you worked with your student medical license, if you volunteered, if you, whatever. Your personal qualities, motivation, dedication, research as well. I know there are many doctors, professors who actually publish on a regular basis. Seek help from them. I know they're very willing and very eager to help. So you can do that. Language, if you have a C1, it's better than having a B2, of course. But the more languages also they have, the better. I know in Norway especially, they really like if you speak Russian or if you speak Sami. And basically local connections as well. If you've worked here in Norway before, or if you've done an internship here, the more likely you're gonna get a position in the hospital. So the more people that you know, the better. Then there's the application text, how good you've written or how good The application test, basically how well you're able to convince them to hire you. The chances of being accepted, it takes several rounds before you actually get accepted, usually 2 to 4, usually it can go up to 6. It really just depends, but usually it's 2 to 3. And once you're in the system, you're free to choose whatever specialty you want. I know psychiatry is harder just because the positions are less, but you're able to choose whatever you want. And whilst you wait for specialty or residency, then I advise that you work and do research. Sometimes research can actually substitute or replace a work experience. So yeah, do that. So if you're going to work, there's multiple types of temporary work. You can work with your student medical license. You can work as a GP, that is a fastlege, acute mutlaq in the emergency department, or basically any department. But the downside to this is that you have multiple restrictions, as in sick leave. Unfortunately, it does not exist. You are unable to ring in and call in sick. You cannot write prescriptions on a blå recept. If you're Norwegian, you know what that is. It means that you don't have to pay for your medication. Yeah, so it's just many restrictions, unfortunately. Whereas with your doctor's license, these restrictions are gone and you can work as a doctor, basically, as any other doctor, but obviously you have a supervisor. You can't work without guidance. But that is the same with the medical license. It's just that this is the only restriction that you have. You can work as a health secretary or a nursing staff, as a biomedical at a nursing home or hospital, but basically any experience counts. Just try and make it as relevant as possible. So the duration of the residency program is first 18 months of obligatory rotations. This is list 1. And depending on your specialty, the specialty that you choose, the minimum years is 5 years of specialty alone. There are obviously opportunities for medical residents to professionally develop themselves, including, there are obviously mandatory lectures that you will be required to attend, but along the way, there are workshops, conferences, and training opportunities. Salary expectations, expect around, in the beginning, 600. If you're already started your specialty, like with the list 1, expect around 600,000 or 650 K Norwegian. I assume that is like $50,000. I haven't done the exact conversions, but you can do that yourself. So my pathway, what am I currently doing? I work at BIP Brine as a junior doctor. BIP stands for Barne- og ungdomspsykiatri. That is children and adolescent psychiatry. And I'm doing this whilst I wait for the 18 months of internship position. Looking back, would I do or would I make the same choice? Sort of. I do not believe that I am in a rush to actually get my residency done and over with. If I could do something different, maybe and possibly work more every summer. Even 3 weeks is more than enough. Get internship positions. I'm currently based in Stavanger, and that is actually where I'm from. So that's why I would specify to working here and not in any other place like in Oslo or Bergen or whatever it is that you want to go to. I recommend getting more work experience. The more work experience, the better. The more research that you have, even better. So start with research early. First years, you can even start now. I believe that the research course, which we had in 6th year, was moved to 1st year. So that is very good. What's the hardest part until now? Just waiting. But again, I'm in no rush, so it's fine. Useful links. There's the license application. There's the hälsodirektoratet, and then there is the actual, there's a PDF which explains how to go through Alt-in and like how to fill it in. There's Alt-in for foreigners. This website I got from the hälsodirektoratet on the first link, actually. It's for the license application. There's a residency application instructions of when to apply, how to apply, through what, through the web recruiter and whatnot. For the application of the residency, as I mentioned, it's through web recruiter. It is the national system used all over Norway. And that's it. Thank you. Any questions?
Thank you, Dr. Jamal. Do we have any questions? We don't have any questions. Thank you so much for the wonderful presentation.
No worries. Thank you for having me.
Okay. Bye.
Bye-bye.
Unfortunately, the presentation for the USA residency is canceled, so that's it for today. We're gonna have a break until later on. Thank you.
Thank you, but I'm pretty sure you're not here for me. You're here to listen to Professor Tsiodras, who is, besides being a great scientist and expert in infectious diseases, happened to be a very nice person, honest person, warm and welcoming person that I'm proud to call my friend for many, many years now. So without further ado, floor is yours.
Good afternoon. Great pleasure to be here, a great honor. To be honest, initially I thought I was not going to be able to come and be with you because I was in Prague yesterday evening at Czechia. But always, you know, when we hear about medical student efforts, you know, it's like a little chord inside our heart, you know, trembles a little bit because we were all in your shoes. And you'll come in our shoes, and you'll want to continue the tradition of being friendly and educators to the younger ones. It's a difficult but popular issue, climate change and infectious disease. And I'm going to try to give you some messages. It's impossible to speak about the entity of this as a whole. It would take months and a special fellowship. This is the United Nations Climate Summit, United Arab Emirates. There was a big story with this, with Dubai a couple of days ago. It was tense because the people presiding this meeting were the people selling oil, the people responsible for carbon and fuel emissions for our planet. But the whole discussion was around these two papers, the ER6 synthesis report and the climate change 2022 report. It's thousands of pages, but there's some strong key messages within these reports that were constructed and reviewed by hundreds of scientists. This is the representative of the Marshall Islands. I don't know if you know the Marshall Islands. There's a group of atolls that have the third commercial ship industry in the world. So they're number 3 in the world as far as shipping. And the highest level in those atolls, these islands, is like 2 or 3 meters. And they're very, very frequently hit by what we call sea level rise. I'll give you an example of what that means in a couple of minutes. He said the Republic of the Marshall Islands did not come here to sign our death warrant. And this is Antonio Gutierrez, the United Nations chairman, who said we cannot save a burning planet with a fire hose of fossil fuels. When we speak about climate change, and you hear about climate change and all the political tension this creates, it's important to realize that we speak about changes that persist for a long time, typically lasting months to years, up to 10 years at a global level. Now we speak more about temperature anomalies, and there's different effects from atmospheric pressure and oceanic temperature that interact in creating these climate change effects that we're seeing. This is a very complicated diagram, so I'm not going to stay at it. I'm just going to pick from it a few things that I will talk about as an introduction to the infectious disease issue. Greenhouse emissions, increased temperatures and rainfall changes, increased ocean heat, rise of the sea level, and drop in ocean acidity, and extreme weather events. This is the greenhouse emissions, and I'm showing you from left to right, carbon dioxide, methane, and nitrous oxide. Record levels in 2022, continuous rise and increase in 2023. Our planet is almost like a red planet from those fumes that circle the Earth. And you can see that this trend has been continuously increasing over the last few decades. So we need a reduction in global greenhouse gas emissions by 2030 of at least 45% to keep the warming of our planet to no more than 1.5 degrees of centigrade. And 1.5 degrees of centigrade is a landmark cutoff point after which we will see great catastrophes in our planet by the end of the 21st century. This is the near surface temperature, what we see when we walk. It was 1.4 plus minus the standard deviation, above the average in 1850 to 1900. So the industrial age, especially after 1950, I don't know if we have a pointer, but I can probably use my cursor here. After 1950, you see continuous rise. 2023 was the warmest year in history. And according to estimates, over the last 100,000 years. And this is exactly the upper curve is what is showing what happened in 2023 across June, April, July, and December. So monthly global surface air temperature is increasing, especially in the 21st century, as you can see with the red color. And for the first time in history, February was the hottest winter on record for several places in the world. And you don't know about the United States. I trained in the United States. I have friends in Chicago and Minneapolis. And those pictures in Chicago and Minneapolis, Minnesota in February are extraordinary because those areas are covered by snow. So there is this report, which is called Seasonal Attribution Report. It's all free in the internet, that showed that from December 2023 to February 2024, collecting data from 175 countries, 678 cities, 6.7 billion people were exposed to unusual winter warmth due to climate change. 1.7, of course, this includes the southern hemisphere that had summer. 1.7 billion people saw greater or equal, at least 31 days, where temperature reached maximum level of 5 on the Central Climate Shift Index. They have some indexes that follow this warmth. And you can see here 2024, to date anomalies compared to the 10 warmest years on record, it's above. And you can see this global land and ocean temperature that is going up. Third parameter. So far we spoke about greenhouse emissions, we spoke about surface temperature, now we speak about ocean heat content. We have 65 years of observation. The highest level over the last 65 years is seen in 2024. How do we know? Is it fake news what you're saying to us today? No. We have special thermometers, special devices that actually they use seals and sea lions that they immerse in deep ocean waters, and they go and automatically they emerge and they take the sensors and the temperature data and record them. And on the right lower picture, you see what happened in Greece, where, and this is last week's data, the strongest, hottest temperatures in seawater were recorded ever, at least 3 to 5 degrees of centigrade in the surface water. There was 20 degrees of centigrade in seawater in Greece. Let's go to another parameter, sea level rise and decrease in Arctic ice. You heard about it. It's rising by millimeters every year, but it's going to be significant, and it is significant. These are data that I'm showing you from 1993 to today. And in the right lower middle part is the decrease in Arctic ice that affects, of course, biodiversity and leads to increased sea level rise in several cities in the world. At least 30 of those cities are at high risk for flooding, and several important European cities like Amsterdam, Hamburg, and Copenhagen are among this list. And this is a paper in Nature in 2024, where they're talking about disappearing cities on the US East Coast. They cannot do ice skating in the Netherlands anymore. They used to have all those frozen rivers, frozen lakes that would go ice. Now they pay special amounts of money to go do ice skating on the glaciers. And this is a picture from Alaska. But what's happening there? Even glaciers melt down. Permafrost thaws. Rivers and streams are turning orange. And you can see a satellite picture on the right part. It's not showing very well. Maybe we can close this row of lights so you can see the picture better. But in Alaska, streams are turning orange as permafrost thaws. And my friend that I met during the pandemic, a physicist who deals with the changing climate conditions around the world, is claiming that the permafrost has hidden deep inside it old pathogens. Like it's gigantic in terms of molecular microbiology pathogens like pithoviruses. And this is the way they study them. They take cylinders of ice deep from the permafrost and they analyze it in the computer. And they do their paleontological experiments. And you can see here electronic pictures of some of the viruses that they discovered in this permafrost analysis. Paleobiology is a very interesting subspecialty, and they got the Nobel Prize, I think, a few years ago. Not for this work, but for other work that has to do with our DNA and the evolution of our DNA. Ocean acidification. You see here on the left upper part that the ocean pH is going down. Why is it going down? Because the ocean water, the ocean itself, has an ability to absorb CO2, carbon dioxide. And as it absorbs carbon dioxide, the pH goes down, and the biodiversity, of course, is extremely affected. Coral reefs around the world, the most famous in Australia, are dying. Living creatures that have life and sound of their own, if you listen to videos in the internet. And this ocean acidification has great effects, of course, on marine microorganisms and degrades the habitat of several other organisms living in the sea. And gives rise to bacteria that find great conditions. And I'm not showing you data from Florida and the green tides in Florida, which is well known in the literature. I'm showing you the white tower of Thessalonica. I don't know if there is anybody from Thessaloniki here, but if the lights were a little bit dimmed, you could see here the red hue of the water, and that gives rise to these microorganisms that thrive in this environment of high temperature and lower pH. And of course, last but not least, extreme weather events. Thank you so much. Appreciate it. Hurricanes, storms, heat waves. There's a phenomenon here which is called the heat dome. I don't have time to speak about it. Wildfires, they destroyed a vast amount of land in Canada last year, and of course in poor Greece. Air pollution, the glaciers melting, we talked about it, and flash floods. And you probably all heard about it a couple of days ago, that there was an apocalyptic sort of picture in Dubai, United Arab Emirates, where floods shake the picture-perfect Instagram city. And it's amazing how one day of heavy rainfall can destroy an image of a country that's advertising its wealth. And apparently they've been doing this experiment since 1990, where they bombard the clouds with iodine silver to condense the cloud substance, so it pours down rain. It increases the chance of rain by 20-25%. And they do that with special aeroplanes that you see on the upper right picture of this slide that bombard the clouds. And they've done that on Sunday and Monday. The pouring came down on Tuesday, and they said that it's not related to this. Experts said that from England and elsewhere. But there is another mechanism that higher temperatures cause extreme rainfall. For each degree of centigrade going up, the temperature, we have 7% increase in moisture. So the moisture in the clouds increases by each degree of centigrade in the ground, and we have heavier rains. If you see projections from big institutions for Cyprus and Greece for 2040, which is 16 years from now, you'll see that one of the expectations for Cyprus is heavy flooding, except on top of extreme heat waves and wildfires, and it's the same for Greece. And as my friend Jan Semeza, who left ECDC, was saying, it's a cascade of events, and it's an interaction of hazard, exposure, and vulnerable population, because flooding affects food chain in Africa, and displaces 1.2 million people because they have no food. So it's an interaction, it's not that simple. And infectious disease comes on top of this. And I'm not going to stay on this slide. What I'm going to show is several different health outcomes associated with all of this. The hazard concept, the health risk concept, which has, of course, the extreme weather events we talk about and the others. And the exposure that has to do with health workforce, with infrastructure, with people and communities. And I'm going to focus on this, which is the health outcome issue that has to do with respiratory illness, with waterborne diseases, zoonosis, vector-borne diseases, and of course non-communicable diseases. I don't have time to talk about all of this. I'm just going to touch on infectious diseases on the second part of my talk, which starts now. Multiple pathways for effects of all the things we describe with infections. The distribution and ecology of the vectors is changing, leading to outbreaks of diseases like malaria and dengue. The quality and quantity of water is affected, leading to outbreaks of diseases like cholera, huge outbreaks in Africa this year, Campylobacter, and other enteric pathogens. And of course, last but not least, 45% of all the deaths under 5 years of age, my dear colleagues, are due to undernutrition. And climate change affects procurement and safety of food. Actually, it's scary that the only vegetable that you will be able to grow, not in great special structures, but in the nature, in Greece, over the next 20-25 years, is going to be cotton. Forget about olive oils, lemon trees, and all the good things that we know about. Let's touch on vector-borne diseases. This is the malaria report by WHO that showed for the first time, and WHO for the first time accepts that climate change drives new cases of malaria, complicating efforts to fight the disease. This is the report. Pakistan, 2.9 million cases. Ethiopia, 1.3 million more cases in 2022, because the 23 report goes up to December 22. And Papua New Guinea, 600,000 more cases. Why in Pakistan? Massive flooding events in 2022. 1/3 of the country went underwater. 33 million people were displaced. 3.2 million patients with malaria, when in 2021, only 275,000 cases of malaria were reported in the country. And malaria spread to new geographical areas. Apparently, some of the mosquitoes in the Asian continent traveled or migrated to Africa. In other countries like Zimbabwe, one of the most well-described is Anopheles stevensii, and for the first time in Africa created huge urban outbreaks. Malaria is a disease of the fields, not of big cities, and there was this big scare with Anopheles stevensii, and they found that the source of replication of this parasite were the huge construction sites in the city, where they had these pools of water where they used to create cement. The projections, according to the reports I showed you, and ECDC are harsh. Increased suitability of the Anopheles vector for Europe, increase in population at risk. But remember, it's not a simple situation. And I don't have time to talk about the vectors of dengue that replicate in higher temperatures, but up to a point, characteristics of the mosquitoes, like the biting rate and the mortality rate, are good for the mosquito. But after a point, which the point, as you can see there, is around 35 degrees centigrade, they start dying and they bite less. So it affects mosquitoes. It's not only a human thing. Climate affects all of us. Coming to dengue, I had to talk about dengue because it's a big threat right now all across the world, I think. I have huge outbreak in the Americas. The vector and the vectorial capacity increases with warm and humid weather. It's higher than the Anopheles mosquito. 4 to 5 degrees centigrade higher is the best environment. And the isothermic zones, and the upper slide is from 2013, and the slide down is from 2024, and refers to the last year. You can see that dengue sort of spreads northern and southern climate regions. And the suitability of the vector is all over Europe. And they speak about the Asian tiger mosquito and the African tiger mosquito, Aedes aegypti, which is on the left, and Aedes albopictus. They do not differ in their vectorial capacity for dengue. So it's important to remember this. And the European outbreaks vector was Aedes albopictus, the Asian tiger mosquito. The one we have here in our yards. We have it in Athens. You have it in Cyprus. You have Aedes aegypti in Cyprus. So we're worried about this breaking record thing in the Americas. We believe ENSO phenomenon and the southern oscillation is behind it, and the El Niño phenomenon, another climate thing. But in March 2024, we had an increase of 249% compared to the same period 2023 in the Americas. They asked for help. Southern oscillation, which is fluctuating ocean temperature in the central and eastern equatorial Pacific, coupled with changes in the overlying atmosphere, leads to this wet and cold versus warm and wet versus dry and cold areas in the world that are associated with vector increases, as described by Sir Walker. And we started with Brazil. Welcome, Professor Petrikos. We start with Brazil with a huge outbreak of dengue in 2024. They bought the entire stock of Qdenga vaccine from a Japanese company, and there's no vaccine left for the rest of the world. And they vaccinate little kids. This is pictures from Chad, Bangladesh, Colombia, Brazil, Peru. Can you imagine in Cyprus or in Greece having to hospitalize patients like this, and what will happen with the cannibals that I call journalists. Can you imagine pictures like this in hospitals in the region because of huge outbreaks of dengue? There was a big outbreak of dengue in Greece in 1927, where 40 people were dying every day, and at least 100,000 people were infected. And they used to give them lemon juice, and of course fake news predominated back then as well, and people were believing those fake news more than science. But this is, can you imagine taking care of patients under this condition in Peru? And there's a huge push right now for vaccine. Big pharmaceutical companies are trying to create more of these new vaccines and give it to patients. Puerto Rico was declared as a public health emergency area because of this huge surge, and that happened on March 28, 2024. This is a few weeks ago. And of course, big papers that have not been published yet. This was announced in October 23 in a big tropical meeting, where they modify mosquitoes with a parasite called Wolbachia, and the Wolbachia parasite either affects the vector lifetime or the transmission rate of the disease, and they create these massive mosquito factories in Brazil that will produce up to 5 billion bacteria-infected mosquitoes per year. And I know for a fact that Cyprus did something similar, freeing approximately 100,000 mosquitoes per week, starting last summer, to reduce the rates of replication of Aedes aegypti. And they're doing good surveillance, airport surveillance here in Athens and in other areas to see if Aedes aegypti will predominate in Europe. But we don't need Aedes aegypti. Aedes albopictus is okay. So we have climatic suitability, we have the presence of the vector, we have the diseases, and we have the outbreaks. This is a chikungunya outbreak that happened a few years ago in Italy and Spain, and last year we had outbreaks of dengue in France, Spain, and Italy. A lot of local outbreaks. So dengue is a real threat for Europe. And I'm sure over the next 5 years we'll see huge outbreaks of dengue. Let's hope I'm wrong. And the report I showed you in the first slides again predicts rise. West Nile virus, it's already here. The mosquito, the common mosquito, lives in your yards as well. This is areas of Europe where the mosquito has been reported. 2018, we had a huge outbreak with early increase in cases due to increased temperature, increased rainfall, and increased mosquito population. What worries me a lot is when it started more than 10 years ago, it was in Southern Europe. Now it's, as you can see, and with surveillance improving, you can see it in Germany, in equids, horses, birds, and humans. Again, reports are, and estimates are that we will see more of it. And unfortunately, there's no enhanced mosquito everywhere in Europe. We need to enhance vector surveillance. We need money. We need political commitment. We need collaboration between science. Foodborne and waterborne diseases, multiple biases in the literature. I'm not going to stay a lot, especially for drought, but for flooding, there is an association with increase in diarrheal diseases due to enteric pathogens like parasites, enteroviruses, Campylobacter, and other pathogens. Vibriosis is the most well-known one. This is pictures from Baltic Circle where people bathe in warming waters, and they get this Vibrio disease by eating oysters or bathing in waters or exposing their wounds, especially if they're diabetic or immunocompromised, and they die from it, or they get really sick. This is the beautiful Baltic Circle, but tourists from Germany, Denmark, Finland, and Sweden have been affected by Vibriosis over the last few years. And of course, extreme weather events, the new climate reality. This is an American broadcasting channel that was talking about floods and fires and Greece struggling on the front lines of our climate reality. And these are pictures from the United Kingdom, January 24, big flood, and a picture from Dubai Down on the right, I talked to you about Dubai. Vector-borne diseases and leptospirosis, among others, can be associated with flooding events. We know that from previous studies in Indonesia, on the upper left part, in Thessalia, Greece last year with the big flood events. We observed a lot of cases, at least 50 cases of leptospirosis and 2 deaths. And microorganisms, sustenance and survival in the soil. This is an epidemic of Cryptosporidium species in Halle, Germany. The public health authorities came out and said kids should not play in areas where there was flooding because this organism stays in the soil, and kids, touch the soil and eat everything, that's in there as well. So there's a new field coming together over the last few years called disaster microbiology. And you can see here, just in the middle, the dust storm that's associated with huge outbreaks of coccidioidomycosis. And this was a lecture I heard in Boston last October, where this area that you see down here is Phoenix, Arizona. And the big thing you're seeing coming is a dust storm. It's not a movie. It's not a Hollywood movie. And cases continue to increase, approximately 500,000 per year. Professor Petrikos is a world-known expert in fungi. And there's a seroconversion, 25 to 50% of the military recruits there, and 80% of the lay population. And this grow and blow hypothesis, where heavy floods and rainfalls 6 to 12 months prior are associated with increase in these airborne microorganisms. They have drones that go on the atmosphere and collect this dust and study it from fungi and find cocci and other fungi. Firefighters have big outbreaks, recent publications. And there is this talk about the game. And you probably know about the game. I did not know about the game. It was called The Last of Us. Probably some of you have played it. And the big series came out in TV advertising this new thermoadaptive fungi that creates havoc in humanity, kills almost everybody, and the heroes of the game try to survive. It's not close to reality yet. It may take years, may take decades, it may never happen. But thermoadaptive fungi in the laboratory and in nature have caused huge outbreaks over the last few years. One of those is Candida auris, and this is the paper that was published in Lancet Microbe 2024 by a very well-known group that shows outbreaks of fungal disease and explains the mechanism of thermoadaptation. I encourage you to read. The more you read, the better doctor you're going to be, and you get the whole picture of what's happening around you. And all these outbreaks that happen around the world that are associated with natural disaster events and are due to fungi. Enough with infectious diseases, and I'm reaching the end of my talk. Is it only infectious diseases? No, of course not. Could it be cardiovascular disease as well? Yes. 35 countries, 11.1 million deaths, huge meta-analysis in BMJ, increased risk for cardiovascular disease that persisted for at least or about 50 days. Is it associated with cancer? We do not know enough yet. Paper in Nature last summer showed that in non-smokers, in Petri dishes, in experiments involving human cells that were exposed to microparticles, the famous ppms, increased expression of proto-oncogenes within the cell. So the polluted atmosphere we're breathing, even if we are not smoking, can give us cancer. And we'll know more about it over the next, you'll know more about it over the next decades. Firefighters, for sure, have an increase in lung cancer from 8 to 43%. And the committee meeting in Dubai the harsh hit Dubai, decided to triple the amount of renewable energy, to stop deforestation, to curb the release of methane. We'll see. I don't believe anybody of them. I don't believe politicians anymore. Chinese are talking about sponge cities that will absorb flood water. Americans speak about heating the surface of the earth with tons of ice as a protective shield against the sun radiation. They invest hundreds of millions of dollars instead of giving them for food in Africa to save glaciers, renewable energy, and this is a skyscraper made of other material, extremely flammable, if you ask me, in the Nordic countries. We have weather AI models by Chinese companies and Google flood forecasting. You can see it in your phone. I did it myself. And it remains a big challenge. We need scientists to study this more, to quantify the effects, the complex interactions, the climatic versus no climatic drivers, the vulnerability of the population. And this from the report. For Europe, it's going to be mainly heat-related illnesses, heat stress during the summer that will cause deaths. For Africa, we will have cholera, we'll have malaria. Let's hope that over the next decades, we will not see outbreaks of infectious diseases like the ones I mentioned in Europe. In conclusion, climate change is an important factor, but not the only one. It's already affecting vector and infection distribution and incidence in affected countries. There's lots of geographical disparity. There's a lot of special interest of vector-borne diseases with expansion of ticks and mosquitoes. And we expect an increase in food and waterborne diseases. The risk assessment is extremely difficult, complex transmission cycles and determinants like the ones I showed you about the mosquitoes. And of course, we need early warning systems and preparedness, combination of surveillance data at the human-vector environment interface. So we can save the Galapagos turtles, the oysters and other sea mollusks in Albania, the cows dying in Africa, and the pyramids that have been hit by the sandstorms in Africa. We need to decline gas emissions, to decrease gas emissions by 43% at least by 2030, and believe me, we're not on the way. Health benefits far outweigh the cost of meeting climate change goals. The threat is here. I encourage you to read this article from the New York Times. It's a week ago, I think. I'm a doctor. Dengue fever took me, even me, by surprise on vacation. He went to Puerto Rico. He didn't know about it, and he got severely ill when he returned to the United States. The WHO organization of the Americas, the Pan American Health Organization, called for collective action in response to the record increase in dengue in the Americas. The Imperial College in London has 9 things you can do about climate change. In Boston last October, I heard this group of doctors that they made this coalition. They're going to do everything in their life, in their daily life, to decrease effects of climate on their environment. Their hospital waste is extremely an extreme burden on the climate, on walking to their work every day, using the bicycle, and other very, very simple things that one can do. I think we're obliged as scientists to protect science and protect our future. Thank you so much. So I'm open to questions if you want, or it's a keynote session, so whatever you want.
Thank you, Professor Theodoros, for your enlightening keynote address. Now we will welcome Professor Petros Agathokleous, President of the Cyprus Medical Association.
Good evening. Congratulations, Professor Theodoros, for such a indeed enlightening and very frightening futuristic statements after what we have seen now. But I do remember your excellent lecture lately in the International Cardiology about the ecological negative impact on the cardiovascular diseases and being cardiologists. I don't know where we start, from cardiogenetics or from cardioclimate diseases at the end of the day. Dear future colleagues, dear students, dear colleagues, Professor Patrikios, Professor Petrikos, it is a great pleasure and honor that I'm here with you tonight just for closing comments. I really congratulate the organizers for the 6th Cyprus Annual Medical Students Meeting. As Medical Association, we are honored to be part of being invited to your event, an event that embodies the spirit of collaboration, innovation, and excellence on medical education. Your dedication, hard work, and unwavering commitment to fostering international communication and collaboration among medical students are truly commendable. By organizing this conference, you have treated a platform for the exchange of ideas, the sharing of experiences, and the exploration of cutting-edge advancement in medicine. This meeting, the annual meeting, serves as a beacon of inspiration for aspiring medical professionals, providing them with invaluable opportunities to engage with the latest ideas, methods, and advancement in our field. The Cyprus Medical Association encourages the collaboration and strongly supports your efforts on building a powerful global network among medical students. By connecting students from different countries and cultures, this meeting empowers all of them to explore and exchange their academic knowledge and interpersonal skills, paving the way for their future success as medical professionals, practitioners, and researchers. Your commitment to excellence and your passion for advancing medical education are truly inspiring. Once again, I extend my warmest congratulations for the contributors of all of those who have made this conference possible. Let us take this opportunity to reflect on the lessons learned, the connections made, and the friendships forged during this enriching experience. We are addressing as students, but actually you're doctors in the verge of getting your stethoscope onto the patient. You're already part of us, where you're already part of our scientific community, medical community. And I congratulate you because you've invited renowned speakers and key opinion leaders on certain aspects of your program, like Professor Theodoros, and this is something that you need to follow, this need to keep on continue medically educate yourselves. This is not only at the level of medical school. You should carry on studying. That's why the continuity in the medical education is a very important tool for you in order to be able to enjoy lectures like the one was delivered a few minutes ago. And I really, really want you to stick to this advice, because unfortunately, as you get into the medical profession on your daily to daily clinical practice, we get forgotten that there is a drastic speed. It's a Formula One speed, the knowledge and all the things that they're up to becoming. And you need to attend seminars, you need to read journals, you need to join networks, webinars all over. Because if I was in Cyprus to record the attendance rate on high-level international seminars, I'm very, very sad to record very poor outcomes of young doctors, young professionals who've just come into the practice, and they don't worry about education anymore. Medical school, residency, it's good to give you the foundational knowledge and the confidence level to examine patients and get into the really rough specialties like intensive care, cardiology, and all over. But epidemiology, infectious diseases seems like is giving us more challenge to get to know more. And it's something that you need to get as a message. So we thank you for inviting us, and we look forward to your program next year and to the high level of this program to be carried out. Thank you.
Thank you, Professor Agathangelu, for your enlightening remarks. It's time for us to welcome our chairs of CAMeSM, Paulina Antoniou and Lorenzo De Fraia, who will say a few closing remarks.
Dear esteemed guests, dear faculty members, and dear students as well. So as we draw the curtain on the 6th edition of the Cyprus Medical Students Medical Association, it fills me with immense pride and gratitude to stand here before you. These past few days has been a wild wind of learning, collaboration, and inspiration. We have witnessed the attendance of many great minds, the exchange of ideas, and the forcing of lasting connections. One of the hallmarks of this year's CAMeSM has been the 9 residency workshops that we had the pleasure to see here, to get enriching speeches of understanding and expanding our horizons in how to approach the next steps of graduating. From cutting-edge medicine research to innovating approaches in education, each workshop has left us with a mark on our collective consciousness. I extend my heartfelt appreciation to all the presenters who shared their expertise and insights, guiding us towards the excellence in our respective fields. Moreover, the roundtable discussion has been a beacon of excellence, showcasing the remarkable work being done across disciplines. This discussion has not only fostered dialogue, but also ignited the spark of innovation, propelling us towards new frontiers of knowledge.
Thank you, Paulina. Organizationally, this year CAMeSM has been a testament of meticulous planning and seamless execution. From registration to logistics, every aspect has been flawlessly coordinated, ensuring a smooth congress for all the participants. And extend my sincerest gratitude to the organizing committee of the 6th year CAMeSM, whose dedication and hard work have been instrumental in making this whole event possible. I would like also to take a moment to acknowledge the poignant documentary on tuberculosis that was screened during the Congress previously. Through powerful storytelling and graphics and compelling narratives, it has shed light on the challenges that we face every day in combating this global health crisis. Last but not least, none of this would have been possible without the biggest support we had from from the faculty members of the European University Cyprus School of Medicine. Your mentorship and expertise has been of great value. As we bid farewell to this year's Congress, let us carry forward the knowledge gained, the connection we made, and inspiration we all gathered. Let us continue to push the boundaries of innovation, striving towards a future where healthcare has no limits. Thank you all once again for participating and making all this event possible. Here's to the success of the 6th year Cyprus Annual Students Meeting. To many more here, to many more years of collaboration, discovery, and excellence. Thank you all very much for coming.
And that concludes the closing remarks of CAMeSM 2024. Thank you all for joining us, and we hope you have a wonderful time at the conference. Feel free to join us for a wine and cheese outside of the Cultural Center. Thank you.
Ναι, αυτό, that's what I was doing. I just injected. There we go. Εμείς ευχαριστούμε.
Ευχαριστώ, να είστε καλά. Συγχαρητήρια.
Ευχαριστούμε πολύ.
Yeah.